Hello students, welcome to the rapid revision course in psychiatry. In this course, we would try to focus on the high yield topics and would try to cover as much of the course as possible. So let's start. So beginning with the basics. Now we have seen in the last couple of years, the examiners are asking more and more questions from this chapter of basics, and that is why it is very important to spend some time on this chapter. So first things first, the term psychiatry was coined by this gentleman, Johann Christian Riehl. We need to remember his name. It has been asked a couple of times in the exams. So, say a patient with a psychiatric disorder comes to you. What is the first thing that you will do? Of course, it would be the history taking. Now, the history taking in psychiatry follows the same format as we follow in any other branch of medicine. However, there is a small difference. The role of the informants is at times equally important and at times even more important than the role of the patient himself in giving the history or providing the history. So we have to give a lot of importance to who the informant is and whether he is reliable or not. So because the informants play an important role in giving the history about a psychiatric disorder, we have to ensure that the person who is providing the history apart from the patient is reliable enough. Now AIMS last year asked this question, that what are the criteria for reliability of informant? When do we say that an informant is reliable? Now the informant must fulfill the 5 C's. There are 5 criteria, all of them start with the alphabet C. Hence we say that there should be 5 C's that must be fulfilled before we call an informant as reliable. So what are these 5 C's? The first C is consistency. It means that the history that the informant is providing remains consistent. The history that he provides in the morning to the resident and the history that he provides to, say, the consultant in the evening, it should remain same. It should not vary. So, the consistency. Second is coherence. The history should make sense. The first part of the history should be meaningfully related to the second part of the history. There should be a flow of history. So, coherence is very important. It should be making sense when put together. Chronological information. The informant should be able to give the history in a proper, timely manner, which means how did the illness start? What were the initial symptoms? How did the symptoms progress? All these chronological information should be provided by the informant. Closeness with the patient. The informant should be close enough with the patient to know the exact history. Say the informant is living in an entirely different city, does not have any regular contact with the patient. In that case, he cannot give the right history about the patient's illness. And lastly, the concern with the patient. The informant should be genuinely concerned with the patient. In case you doubt the intention of the informant, you would not accept the history given by the informant. For example, say the brother of the patient comes to give you the history, but you also know that the brother and the patient, they have been fighting over, say, some property dispute for the last 10 years. Now, you would not accept the history given by the brother on its face value because you are doubtful that maybe some amount of malified intention may be there on the part of the brother. So we have to be sure that the informant is genuinely concerned with the patient. So these are the 5 C's. After the history taking is completed, we go towards the examination. And now this is a very important topic. The clinical examination in psychiatry is called as mental status examination. Now this is a favorite question of the examiners, the one-liners. The clinical examination in psychiatry is called as option 1 MSc, option 2 PSc, option 3 MMSc, option 4 DSc. The answer is MSc or mental status examination. Now, so when we do the mental status examination, we examine various aspects of mental functioning. Let us find out what are these aspects. So when we do MSc, the first thing that we comment upon is the affect and mood. So what is affect and what is mood? We often say that today my mood is not good. When a person says that today my mood is not good, what is he referring to? He is basically referring to emotions. Both these terms, affect and mood, refer to emotions. In fact, it is a common question. Affect is option 1 perception, option 2 memory, option 3 judgment, option 4 emotions. The answer, of course, is emotions. Now, again, two questions. Which part of the brain generates the emotions? And which part of the brain regulates or controls the emotions? So the generation of emotion is, I'm sure you must be knowing this by now, limbic system. The emotions are generated by the limbic system, but the emotions are controlled or regulated by the frontal lobe. That makes sense. For example, say you are sitting in a class and you are reminded of a joke and you suddenly feel like laughing. But you would suppress yourself, you would stop yourself from laughing. Which part of your brain would be stopping you? It would be the frontal lobe. Let us talk about some abnormalities of emotions which are asked in the exams. So, the first one is what is called as labile mood or emotional lability. Now, what is the meaning of lability? Labile is something which is not stable. The typical question that comes in the exams is a patient comes to your OPD, he is laughing at one moment and he starts crying the next moment without any reason. What is it called as? The emotion is unstable, emotion is fluctuating a lot. This is called as labile mood or emotional lability, and it is a feature of mania. What would be the exact opposite of emotional lability? In emotional lability, there is too much emotion fluctuations. What would be the opposite? A person whose emotions do not change at all. If you say a joke, this person does not get happy. If you go and slap him, he does not get angry. The affect or the mood does not show any response. Or in other words, the affect is flat. So this is called as affective flattening, or also known as emotional blunting or blunt affect, where there is lack of emotional responsiveness. Flat affect or affective flattening is a feature of which illness? Of course, schizophrenia. Alexithymia. Alexithymia is defined as inability to express your own emotions and inability to understand others' emotions. Neither you are able to express yourself, and if somebody else is expressing his emotions, you are not able to understand it. For example, say if I have alexithymia and you are standing in front of me and you smile. Now, normally, by looking at your smile, I should be able to deduce that you must be happy. That is why you are smiling. But if I have alexithymia, I would not be able to understand that. So, inability to express emotions and inability to understand others' emotions. And lastly, we have got anhedonia. Most of us know about it. Anhedonia is inability to experience pleasure in previously pleasurable activities or interactions. Things that used to make you happy in the past do not make you happy any longer. This is anhedonia. Let's talk about the second component of MSc, which is perception. Now, in very simple terms, what is perception? Any information coming through a sensory organ would be a perception. Now, we have 5 special sensory organs and we have the 5 basic perceptions. We have got the auditory, visual, olfactory, gustatory and tactile, right? You hear, you see, you taste, you touch and you smell. These are the 5 special senses. Now, we are more concerned or we are more interested in the abnormalities of perception. So, if I say that I see a black pointer in my hand, is it a normal perception or abnormal perception? It is a normal perception. In second case, I say I see a black umbrella in my hand. Is it a normal perception or abnormal? It's an abnormal perception. In the third case, I say I see a black umbrella in my hand. Normal, abnormal? Obviously abnormal. But the third one was different from the second one. In second one, there was a pointer in my hand, but instead of the pointer, I saw an umbrella. In the third one, there was nothing in my hand, but I still saw an umbrella. Second is the example of illusion. Third is the example of hallucination. So what is illusion? Illusion is false perception of a real object. Something is there, but you are perceiving it falsely. For example, in your exams, they always throw this question. A boy is walking down a road and he mistakes a rope for a snake. What is this called as? If you are mistaking a rope for a snake, what you are doing is you are falsely perceiving a stimulus. This is obviously an illusion. Hallucination, on the other hand, is false perception in the absence of any object or stimulus. There is no object, but you are still perceiving something. The third case, when I said, I see a black umbrella. The problem is, this definition of hallucination is oversimplistic. How? Let us take an example. For example, if I ask you that close your eyes and try to imagine the face of, say, Deepika Padukone, would you be able to see her if you close your eyes? The answer is yes, you can see her. So is it a hallucination? Because there is no object here, but there is a perception here. The answer is no. I mean, all of us cannot be hallucinating at the same time. That brings us to a very important topic. What are the criteria for diagnosis of hallucinations? We must be able to fulfill 4 criteria before we can call a perception as a hallucination. The first criteria is the definition itself, that hallucinations occur in the absence of any object or stimulus. The second criteria is hallucinations are as vivid as a real perception. What is the meaning of vividity? Vividity means detailed or detailedness or clarity. Now, when we have a real perception, for example, if you are seeing somebody, let's take the example that you are looking at my face or you are looking at me on a mobile screen or your tablet screen, I am a real perception for you. You are seeing me in great details. What is the meaning of great details? You can see that I am wearing a specs, you can see that I am wearing a blue shirt, you can make out the tone of my skin. All these things you are able to see clearly. This is the quality of a real perception. When we see someone, we see them in great details. Hallucination is also equally vivid. When somebody has a hallucination, say I'm seeing a man standing here and I'm hallucinating. When I see this man, I would see him so clearly that I would not be able to differentiate between the reality and the hallucination. So hallucinations are extremely vivid. They have the lifelike quality. On the other hand, imaginations, they are not vivid. For example, again try closing your eyes and see the face of Deepika Padukone. When you close your eyes and when you imagine the face of Deepika Padukone, it's not a vivid face. It's a hazy face, right? Imaginations are hazy. The third criteria, hallucinations occur in outer and objective space. Now, what is outer and objective space? Anything occurring outside your body. For example, if you are looking at my face, at this point of time, you are seeing me in your outer and objective space. I am outside the body. But where do we see Deepika Padukone? We see her within our mind. Anything inside the mind is inner and subjective space. And the last criteria is hallucinations are not under willful control. If I am having hallucination, neither can I start those hallucinations nor can I stop those hallucinations. But what about imaginations? What about Deepika Padukone? She is in my control. Whenever I feel like, I close my eyes and I see her. Whenever I feel like, I open my eyes and she disappears. So imaginations do not fulfill the criteria number 2, 3 and 4. That is not important. What is important is what are pseudo hallucinations. Nobody is going to ask you the criteria of imagination, but people have asked the criteria of pseudo hallucination. So what is a pseudo hallucination? If the criteria number 1 is fulfilled, if the criteria number 2 is fulfilled, and the criteria number 4 is fulfilled, but instead of criteria number 3, instead of outer and objective space, the perception is occurring in the inner and subjective space, then we call it a pseudo hallucination. So the third criteria is not fulfilled, the rest of the criteria are fulfilled. Sometimes for pseudo hallucinations, we use the term seeing with mind's eyes. Right? Seeing with mind's eyes means nothing but that the perception is occurring in inner and subjective space. Alright, let's talk about a specific hallucination which is extremely important for our exams. It is called as reflex hallucination. Now, what is reflex hallucination? Stimulus in one sensory modality produces hallucination in another sensory modality. The stimulus is in one modality, hallucination is in another modality. For example, if I say, that whenever I hear the noise of an air conditioner, the stimulus is in auditory modality. Whenever I hear the noise of an air conditioner, I start seeing Deepika Padukone in the recording room. What is happening here? The stimulus was auditory and it led to a visual hallucination, and that is why it's a reflex hallucination. So basically it is a type of synesthesia. It is a type of syn means combination, aesthesia means sensation. It's a morbid variety of synesthesia. Why morbid? Because it is usually seen in pathological conditions like intoxication with either cannabis or a hallucinogen like LSD. Usually seen with cannabis and LSD intoxication. Alright, let's talk about the third component of MSC, which is thought. Now sometimes the term cognition is used interchangeably with thought, which is not a very good way of describing thought, but it is done. So sometimes even they ask you this question that cognition is option 1 perception, option 2 emotion, option 3 thought, option 4 something. Your answer would be thought. Whenever we describe the thought of a patient or a person, we describe it according to 4 subheadings. We describe it along 4 subheadings. The first thing that we describe is the stream of thought or the flow of thought. Now what is stream of thought? It basically talks about the speed of thinking. With what speed thoughts are coming in my mind. That is my stream of thought. For example, if I say, my name is Dr. Praveen Tripathi. I did my MBBS MD from Delhi. Currently I am working as a psychiatrist in Delhi. What is the rate of the thoughts that are coming in my mind? It is normal. But if I say, my name is Dr. Praveen Tripathi, did my MBBS MD from Delhi, working as a psychiatrist in Delhi, exact same thought, the speed has gone up. So this is the meaning of stream of thought or the flow of thought. Now one of the important abnormalities of flow of thought that is often asked in the exams is the flight of ideas. If you look at the definition of flight of ideas, it says, in flight of ideas, the speed of thinking is increased and the connection between the thoughts appears to be due to chance factors such as rhyming. So what happens in flight of ideas is, the speed with which thoughts are coming in the mind, it goes up so much that mind has got no time to make a logical connection. So mind starts making connections on the basis of random things such as rhyming. For example, a patient comes to you and she says, my name is Lily, I live in Delhi, I have a big belly, Ellie Melly Belly. What is the connection between all these things? It's rhyming. They are rhyming together, right? So, say, this is the example. What is the basis of connection? Rhyming. Mind did not have any time to make logical connections, so it started making random connections. This is flight of ideas. And in which condition would we find flight of ideas? Mania. It is a feature of mania. Alright. After flow of thought, let's go to the form of thought. Now, what is form of thought? The flow of thought was all about the speed of thinking. Form of thought is about the organization of thinking, whether the thoughts are meaningfully connected with each other or not. So to understand it better, let's take an example. Say there are 2 thoughts. The thought 1 is, my name is Praveen and I am a doctor. How many components are there in thought 1? We can say that there are 2 components. The first component, let's call it component A. It is, my name is Praveen. And the second component is, I am a doctor. Let's call it component B. And then the thought 2 is, I live in Delhi. And now if you look at this thought, the thought 1 is well connected to thought 2, meaningfully connected to thought 2. And the component A of thought 1 is meaningfully connected to component B of thought 1. Or in other words, the form of this thought is normal. Now, the form of this thought may become abnormal at various levels. So first of all, disorders of form of thought in which the organization of thinking gets disturbed, they are called as formal thought disorders. Right. So abnormalities of form of thought are called as formal thought disorders, and formal thought disorders are characteristic abnormalities seen in patients with schizophrenia. Now we were talking about that the form of thought may get disturbed at various levels. So what are those levels? So this is a normal thought. Say a person develops formal thought disorder. The first type could be the patient comes to you and says, my name is Praveen and I am a doctor. Beijing is the capital of China. What is happening here? Thought 1 is not connected to thought 2. This is the first type of formal thought disorder. Second case, the patient comes and says, my name is Praveen and it is going to be the biggest blockbuster of this year. What is happening? The component A of thought 1 is not connected to component B of thought 1. Second level of formal thought disorder or second type of formal thought disorder. When I say my name is Praveen and it is going to be the biggest blockbuster of this year, though you find it abnormal, but still you are able to make some meaning out of it. You know that I am talking about the name of a person and possibly a movie. In the third type of formal thought disorder, what happens is, I come and say, my name Praveen, okay, China, bye. Now what is happening here? The entire thought is jumbled up to the extent that no meaning is getting conveyed by my thought. So this is a third type of formal thought disorder. So what do we call these types? The first type is called as derailment. Thought number 1 is not connected to thought number 2. The second type is called as loosening of association. The first component of thought 1 is not connected to the second component of the same thought 1. And the third type is called as incoherence. The complete thought is jumbled up to the extent that no meaning is being conveyed by that thought. It is also called as word salad. Why? My Praveen, okay, China, bye. I have made a salad of words. They have been just randomly mixed. The next formal thought disorder is circumstantiality. Now in circumstantiality, what happens? A thought, say it has to go from point A to point B. Instead of going directly, it takes an indirect route. What do I mean by it? For example, say I ask you, in which branch do you want to post-graduate in? And you answer me, sir, orthopedics. Now this is a normal form of thought. Your thought was at A, it had to reach point B, it immediately reached point B, it directly reached point B, which is the normal way a thought should proceed. But say again, I ask you, in which branch do you want to do your post-graduation in? And you say, sir, in the first year I used to like anatomy. Then in the second prof, I started liking pathology. In the third year, the senior resident of ophthalmology was very pretty, so I started liking ophthalmology. In the final year, I thought I would become a surgeon. But by the time I finished my internship, I started thinking that I should get a job. Now I am planning that I'll get a job. With the job, I'll get some money. With the money, I will get married. And after marriage, I will pick a seat of orthopedics. Now what is happening here? Instead of reaching your goal immediately or directly, you are giving me all the unnecessary details that I haven't even asked for. But finally, you are telling me that you will pick a seat of orthopedics only. So this is about circumstantiality. A lot of unnecessary things are brought in, but finally the goal of thought is reached. Compare this with the next formal thought disorder, which is tangentiality. In tangentiality, as you can see, the thought is related to the goal in a distant way, but the goal is never reached. For example, again, I ask you, who is your favorite Bollywood actress? And you say, sir, Bollywood is based in Bombay. The Bollywood movies are mostly about love and relationships. Hollywood is based in Los Angeles, California. And my uncle also lives in Los Angeles, California. And then you stop. Now your answer is somehow related to my question, but you never tell me the answer. You never tell me who is your favorite Bollywood actress. So the goal of the thought was never reached, because in this example you never told me who was your favorite Bollywood actress. This is tangentiality. If you look at the last phrase, the goal of the thought is reached and the goal of thought is never reached. This is what differentiates the two. The next form of thought disorder is neologism. Now this is very important. If you look at this term neologism, neo means new, logism means word. So basically coining of a new word. The patient creates a new word, and how is he creating that word? How is he coming up with that word? That is ununderstandable. For example, if I say that this thing in my hand, it is called as Tintin Tapa. Now Tintin Tapa is a word that I have created. And why am I calling a pointer as a Tintin Tapa? This is beyond your understanding. This is neologism. So after the flow of the thought and the form of thought, let's talk about the content of thought. Now, what am I thinking about is the content of thought. An extremely important question repeatedly asked in the exams is on delusions. Delusions are disorders of content of thought. Right? NEET has asked this question twice in the last 3 years. Delusions are disorders of content of thought. What are delusions? So there are 3 aspects to the definition of delusion. Delusion is a false belief. The patient continues to believe in the belief, continues to hold the belief despite evidences against it, which means the beliefs are firm, fixed and unshakable. Even if you give an evidence, the patient would not accept it, would not change his belief. And the belief is not explained by the background of the patient. So a false belief patient comes up with, you give him all the reasons why your belief is wrong, give him all the evidences, he does not accept those evidences, continues to hold the belief, and the background of the patient does not explain that belief. Why is this third point important? If the patient holds a belief which appears to be false and firm, fixed and unshakable, but the background explains it, then it would not be called as a delusion, it would better be called as a superstition. For example, say a patient comes from a tribal area and the patient says that, doctor, I developed tuberculosis because of the black magic. Now you tell him everything about tuberculosis, about the bacterium, about the test, but he does not accept it. He says, no, TB is because of black magic. Is it a delusion? Well, if you look at his background, the tribe from where he is coming, it is quite possible that everybody holds this belief that disorders are caused by black magic. In that case, we will call it superstition, not a delusion. But say you a doctor, you come to me and you say that, doctor, and that, sir, I developed tuberculosis because of black magic, then I would say it's a delusion because your background does not explain your belief. Alright, let's talk about the types of delusions. The first is called as delusion of persecution. In the delusion of persecution, the basic theme is that people are out there to harm me. The patient may say, police is after me, the intelligence agencies are after me, my brother wants to kill me, my wife wants to kill me. Basically, somebody wants to harm me. 2 things to remember. Overall, the most common type of delusion is delusion of persecution. Secondly, the most common type of delusion in schizophrenia is also delusion of persecution. The second delusion is delusion of reference. Now, in delusion of reference, what happens is the patient starts believing that the neutral events are somehow related to me or are somehow in reference to me. For example, if I have delusion of reference and I see 2 people talking at the back, I will think that they are talking about me. If somebody smiles, I will say she is laughing at me. Everything, even neutral events, has a meaning and it is in reference to me. Delusion of reference. Delusion of grandiosity. As the name suggests, the patient starts believing that he has got some special power or some special role or some special identity. For example, I come to you and I say, I am so powerful that I can lift an entire train with my bare hands. Delusion of grandiosity. Or if I come to you and I say, I have been sent by the God to spread the message of peace and love. Delusion of grandiosity. Or I come to you and I say, I am the reincarnation of God. Delusion of grandiosity. The next one is delusion of love, also called as erotomania or declarambot syndrome or fantasy lover syndrome. Now what happens here is the patient starts believing that somebody from a much higher socioeconomic status is in love with them. For example, I come to you and I say, Katrina Kaif left Ranbir Kapoor because she is secretly in love with me. Now you ask me, sir, did she ever say that to you? I say, no, she sends letters, but they never reach me. Ranbir Kapoor stops all those letters in the middle. This is how patients tell their stories. They'll believe that somebody from a much higher socioeconomic status is in love with them. And when you ask the proof, the reason, they would give something like this. This is delusion of love or erotomania. Then the most dangerous delusion is delusion of infidelity, also known as morbid jealousy or the pathological jealousy. The NEET has used the term pathological jealousy for a question it framed a couple of years back, also known as Othello syndrome after the novel Othello by Shakespeare. So the patient has a belief that the partner is cheating on them. The patient believes my wife is cheating on me, or my husband is cheating on me, my girlfriend is cheating on me, my boyfriend is cheating on me. Basically, my partner is cheating on me. This is the most dangerous delusion, because many a times patients either commit suicide or may commit homicide. Nihilistic delusion. Nihilism means nil, end of everything. So in these delusions, which are also called as delusion of negation or Cotard syndrome, patient may deny existence of things. Patient may say that everybody is dead in the world. The water has frozen. The wind has stopped blowing. My internal organs are rotten. All this is delusion of negation. It is usually seen in patients with severe depression. Now let's talk about the most important delusion of misidentification, also called as misidentification syndrome. In these delusions, patient starts doubting the identity of individual. Now there are two syndromes which are clubbed under this broader rubric of this delusion of misidentification. We have got Capgras syndrome and we have got Frigoli syndrome. Now what happens in Capgras syndrome, patient starts believing that a familiar person has been replaced by a similar looking double who is a stranger. Patient believes that a familiar person has been replaced by a similar looking stranger. So for example, a patient goes back to his home, he enters the drawing room and he looks at his wife. Wife is sitting in the drawing room. Wife is of course a familiar person here. But the patient develops a belief that this woman who is sitting in my drawing room, who looks exactly like my wife, is not really my wife. It's somebody else who just looks like my wife. So what is the history that you will get? Patient goes back home and starts fighting with his wife. That who are you? Why did you replace my wife? How do you manage to look exactly like her? What is your intention? So what is happening here? Patient is believing that a familiar person, wife in this case, has been replaced by a similar looking stranger. Sometimes patients say that you are a double of my wife. That is why it is also called as delusion of doubles, right? The second type, so Capgras syndrome is delusion of doubles. Patient believes that a familiar person has been replaced by a similar looking stranger. The second type is called as Frigoli syndrome. It is kind of opposite of the Capgras. In Capgras, patient was believing that a familiar person has been replaced by a stranger. In Frigoli, what happens is patient believes that a familiar person is deliberately changing her face to look like a stranger. A familiar person is deliberately changing her face to look like a stranger, and the patient believes that the familiar person can take many different faces and can look like many different people. So what do I mean by this? Say there's a patient who has delusion of persecution, that my wife wants to kill me, and he believes that my wife follows me everywhere I go. After some time, the patient starts believing that my wife follows me, and so that I am not able to identify her, she changes her face while following me. So this patient is believing that wife is changing her face while following me. So what is the history that you will get? The patient will go and start fighting with a random woman. He will tell her that you are my wife. You are my wife and you have changed your face so that I am not able to identify you. And not only that, patient will believe that wife is changing multiple different faces so that he is not able to identify her. So, Frigoli syndrome, patient believes that a familiar person is changing his or her physical appearance and disguising as a stranger, and that multiple different appearances can be taken. Lastly, so we have talked about the flow of thought, form of thought, and content of thought. Let's talk about the possession of thought. First of all, what is the meaning of possession of thought? Normally, what we experience, whatever is going in my mind, it belongs to me. It is my possession. Nobody else can have any kind of influence over my thinking. This is the meaning of normal possession, that whatever is going in my mind, it belongs to me. I control it, nobody else controls it. In the abnormalities of possession of thought, what happens is patient starts believing that somehow others can interfere with my thinking process, or that my thoughts are not in my control. So how would it manifest? Say a patient comes to you and he says, "Doctor, something weird is happening. I was sitting in my drawing room, I was thinking about the cricket, and suddenly a very weird and strange thought entered my mind." "Doctor, that was not my thought. That thought was put into my mind by my neighbor who is using some special kind of technology." So patient is believing that neighbor is using some technology and putting thoughts in his mind. This is called as thought insertion. Somebody is putting thoughts in my mind. Second patient comes and says, "Doctor, something weird is happening. I was sitting in my drawing room, I was thinking about the cricket, and suddenly my mind went completely blank. I could not think of anything. Why? My neighbor used some kind of technology and withdrew all my thoughts. He stole all my thoughts to the extent that my mind became blank." This is thought withdrawal. The third patient comes and says, "Doctor, something weird is happening. Whatever I think, my thoughts leave my mind and others are able to catch them. As if my thoughts are getting broadcasted. Yesterday I was sitting in my room. I thought that let me go downstairs to the kitchen and make omelette. And the moment I opened the door of my room, I saw my wife standing with 2 eggs in her hand. Clearly, doctor, my thought left my mind and my wife caught it. She already understood that what I was thinking about. Thought broadcast. Thoughts escape my mind and others can access them." Another abnormality of possession of thought is obsessions. Now, this is a controversial question. Some people say that obsessions are disorders of content of thought. I am telling you, obsessions are disorders of possession of thought. If you go by Fisher's psychopathology, which is the standard textbook for psychopathology, they club obsessions as a disorder of possession of thought. Why? A patient with obsession feels or experiences that he is not able to control his thoughts, because in obsession, the same thought keeps on coming in the mind again and again. But some other textbooks, including the Kaplan-Sadok's Synopsis of Psychiatry, they say that obsessions are disorders of content of thought. The reason being, the standard textbooks classify thought as flow, form, content, possession. Kaplan-Sadok's classify thought as thought process and thought content. So if you follow the synopsis classification, all the disorders of possession of thought would come under the content of thought. But if an examiner is asking you a question and giving the options as flow, form, content, possession, automatically you know that the examiner is following the standard classification, and according to that, obsessions are disorders of possession of thought. So if you have the option possession, you will mark that. If there is no option possession there, then of course you will mark content. Let's talk about, so we have talked about the affect and mood, we have talked about the perception, we have talked about the thought. Let's talk about higher mental functions. The next component of MSC is higher mental functions. The first higher mental function is attention. Now what is attention? Your ability to attend to a particular stimulus without getting distracted. For example, if you are listening to this lecture, you are trying to attend to what I am saying without getting distracted by your WhatsApp messages or Facebook notifications. So if you are able to do so, we say attention is present. When we test the attention of a patient, we use digit span test or digit repetition test. Basically what you do is you speak few numbers in front of patient and then you keep on increasing the numbers that you say. For example, you go with 1 digit, you say 5, patient has to repeat after you 5. Then you go 2 digit, you say 5, 7, patient has to say 5, 7. Then you go 3, 2, 8, patient goes 3, 2, 8. Then you go 3, 5, 7, 6, patient repeats you. And lastly 3, 8, 4, 6, 7. And patient has to repeat it. So if the patient is able to repeat 5 digits, then we say his attention is normal. This is called as digit span test or digit repetition test. In the last 2-3 years, AIMS has been asking questions from the higher mental functions and about these tests. Now, attention is ability to focus on a stimulus. Concentration is ability to focus on a stimulus for long periods of time. Maybe you are able to listen to me for 2-3 seconds, but then you lose your attention. But if you are able to listen to the entire lecture for say 50 minutes, then you will say that you are able to concentrate. So concentration is nothing but ability to sustain attention. And how do we test it? It is tested by using serial 7 subtraction. Basically what you do is you tell the patient that you have to serially subtract 7 from 100. So how does it go? 100 minus 7, patient says 93. Then you say subtract 7 again. 93 minus 7, 86. 79, 72, 65, right? So patient has to do it 5 times. And he has to keep in the mind the figure and then subtract 7. So if he is able to do it 5 times consecutively, then we say that the concentration is normal. The next higher mental function after attention and concentration is memory. Now there are 3 components of memory. The first one is immediate memory, which is memory for interval of seconds, and you test it by using digit repetition test, the one which we use for attention, or the serial 7 subtraction, which we use for the concentration. The second is the recent memory, memory for minutes, hours or days. Here for testing it, you use your 24-hour recall method. If you remember your 24-hour recall method from PSM, something of that sort is used here. You ask the patient, what did you have in dinner the last night? What did you have in breakfast in the morning? So basically 24-hour things that have happened in the last 24 hours, you check them. And then we have got remote memory, which is for years. So you ask patient questions like, which school did you go to? Which college did you attend? And you also ask some historical events like, in which year did India win the World Cup? Or who was the prime minister in that particular year? Things like that. After that, a very important, the most important component of higher mental functions is insight. Now, what is insight? Simply awareness of the illness. If I am ill and if I know that I am ill, my insight is present. If I am ill and I don't even realize that I am ill, my insight is absent. Now, so far so good, absent, present, insight. But now the examiners are going deeper. They're asking you about the grades of insight. So there are 5 grades of insight. Let's talk about them. This year AIMS question, May 2019, about the grades of insight. So grade 1 of insight is complete denial of illness. Patient says, I do not have any illness whatsoever. Grade 2 is awareness of illness but denying it at the same time. Patient says, yes doctor, I hear some voices at times but I don't have any illness. Right? Both things happening at the same time. Awareness but denying it at the same time. Grade 3, awareness of illness but attributing the symptoms to physical or external factors. Patient says, doctor, I hear some voices but it is because of the black magic done by my neighbor. Or I hear some voices, possibly it is because of increased blood pressure. Grade 4, also called as intellectual insight. What happens here is patient accepts that he has an illness, but he does not change his behavior at all. For example, patient comes to you and says, doctor, I have schizophrenia, I know it. But he still refuses to take medications. He continues to consume cannabis. He refuses to have a regular lifestyle. So though he knows it intellectually, he is not using it to change his behavior. And lastly, the highest level of insight, neat question. What is the highest level of insight? The highest level of insight is emotional insight. What happens here? Patient comes and says, doctor, I know I have schizophrenia and that is why every month I come to take my prescription. Every month I meet a psychiatrist. I stay away from drugs. I maintain a regular lifestyle. You know that you have an illness and you use that information to change your lifestyle. So these are the 5 grades of insight. Sometimes we say that there are 6 grades of insight, but now this is becoming the more standard classification. Alright, let's talk about a classification, basic classification in psychiatry, psychosis versus neurosis. Now primarily psychosis versus neurosis was done on the basis of insight. We said that if the patient has insight, this is a neurotic illness. If he does not have insight, it's a psychotic illness. But sometimes even psychotic disorder patients have insight and neurotic disorder patients do not have insight. So a second way of doing it is, or an additional point is, the presence of symptoms If the patient has delusions and hallucinations, we call it psychosis. If it does not, we call it neurosis. That is the better way of classifying disorders into psychosis versus neurosis. Lastly, in this chapter, we talk about the classificatory systems. Now, there are two standard classificatory systems that we follow in psychiatry. Classificatory systems on the basis of which we reach a diagnosis. So we have got ICD, International Classification of Diseases. The 11th edition has recently been accepted, published by World Health Organization. And the second one is DSM, Diagnostic and Statistical Manual of Mental Disorders, which is published by American Psychiatric Association, usually followed in United States of America. Now, most of you are worried about ICD-11. You keep on sending me messages, WhatsApp, Facebook messages that ICD-11, what are the changes? If you look at the WHO website, it says that ICD-11 will be presented at World Health Assembly in May 2019, which has already happened. It was presented and it was adopted by the member states. Look at the next line. And will come into effect on 1st January 2022, right? So ICD-11 has been accepted, but it might take some time before it comes into effect. So for all practical purposes, you still need to remember all the diagnoses of ICD-10. In fact, in all likelihood, the questions on ICD-11 will not be coming this year, maybe even next year. Still, we will go by some important things, some important changes that have happened in ICD-11. But primarily, I think ICD-10 is to be stick to. Right? Don't waste too much time focusing on ICD-11. We don't know whether they are going to ask anything from ICD-11 as of now or not. So this was about basics. We will start with the second chapter now. Alright, let's talk about the next chapter, schizophrenia and related disorders. Let us talk about some historical perspective first, because some of the names are still asked in the exams. So the older name of schizophrenia was dementia praecox, and this this diagnosis was coined by Emil Kraepelin. After Kraepelin, the second person whose name we must remember is that of Eugene Bleuler. Now, Eugene Bleuler changed the name from dementia praecox to schizophrenia. So this is one of the commonly asked questions: who coined the term schizophrenia? The answer obviously is Eugene Bleuler. Perhaps the most important name in the history of schizophrenia is the third one, that of Kurt Schneider. Now, Schneider, why his name is so important is he gave a list of 11 symptoms, and these symptoms are called as Schneiderian first rank symptoms. So he proposed a list of 11 symptoms which are called as SFRS, and these SFRS have got a diagnostic value. Schneider said that if any of these 11 symptoms are present, we can diagnose the patient with schizophrenia. So still the examiners ask you which of the following is a SFRS. So we'll have to remember all these 11 symptoms by heart. Let us try to break down these symptoms into smaller groups so that we are able to retain them in the longer run. So the first three SFRS are called as the three thought phenomena. We already talked about these three symptoms in the last chapter. So the three thought phenomena, the thought insertion, the thought withdrawal, and the thought broadcast. These are the first three SFRS. Put together, they are sometimes also referred to as thought alienation phenomena. The next three symptoms are called as made phenomena. Now, what is made? If I say that you are being made to study for long hours, what does it mean? It means that something is being forced upon you. Now, there are three symptoms that come under the three made phenomena. The first one is called as made volition. Now, a patient with made volition experiences that something which is normally in his control, in his volitional control, is no longer under his control, or he experiences that a particular action is being controlled by somebody else. Let me give you an example to make this point clear. We had a patient in our ward. What he would do is, a patient with schizophrenia, what he would do is every now and then he would stand up on the bed and he would try to put his hand into the moving fan. When you ask him why are you doing so, you would get hurt. He would say, "Doctor, I am not doing it. My arms automatically start moving towards the fan and I do not control it. I feel as if somebody is controlling the movement of my arms. They automatically go up and they move towards the fan. So the patient is experiencing that a particular action is being controlled by someone else. This is a perfect example of made volition. Someone is controlling my actions. The second one is made affect. Someone is controlling my emotions. A patient is sitting in the ward. He suddenly starts crying. You ask him what happened, why are you crying, why are you sad? He says, doctor, I'm not sad. Somebody else is controlling my emotions and is making me cry. Third is made impulse. Now what is impulse? Impulses are the sudden urges, sudden drives. So, for example, you are studying for long hours and suddenly an impulse may come that this is nonsense and where did I get stuck? I should just throw all the books and copies away and leave and never come back. And then you stop yourself that no, this is not right. Let's not be impulsive and let's continue with our preparation. So impulses are those sudden urges or sudden drives. So what happens is in made impulse, the patient may tell you that doctor, the moment I see you, I get a very strong impulse to slap you. And this impulse is being sent into my mind by somebody else. Somebody is putting those impulses in my mind. Till now, I have been able to control myself, but stay away from me, otherwise you will get slapped someday. So this patient is saying somebody is putting impulses in my mind. I am able to control them as of now, but if I lose my control, I might act on those impulses. The three made phenomena. Alright, let's talk about passivity. Now, what is passivity? If you read the definition, passivity experiences are those in which patient experiences that thoughts, emotions, actions or sensations are controlled by others. Any such experience where patient feels that somebody else is controlling my thought or my perception or my actions or sensations would be clubbed under passivity. So, for example, all of these, in made volition, patient is feeling somebody is controlling my action, it's a passivity phenomena. In made impulse, patient is feeling that somebody is controlling impulses, it's a passivity phenomena. In thought insertion, patient is feeling that somebody is controlling a thought, it's a passivity phenomena. So all of these can be called as passivity phenomena. Telling you this because sometimes they have used the option of passivity in their questions and you should be aware of what passivity exactly means. So after the three made phenomena, let's move forward. There are three types of auditory hallucinations which are a part of a component of SFRS. So what are these three auditory hallucinations? Remember that whenever the term voices is used in psychiatry, it is used to refer to the auditory hallucinations. So what are the auditory hallucinations that form SFRS? The first one is called as voices arguing or discussing about the patient, also called as third person auditory hallucination. So what happens here is, say I'm the patient, I will hear at least two different voices. Say I hear voice of an elderly male and a middle-aged female. Now what I hear is, these two voices are talking amongst themselves and they are discussing about me. For example, the first voice says, what I hear is the first voice says, he has been speaking for 2 hours now. The second voice responds, yes, he must be getting tired by now. What do I hear as a patient? Two people, two voices are talking to each other about me. And by third person auditory hallucination, I am being referred to as a he here. And what is he in English grammar? Third person. He, she, him, her, all this is third person. So two voices are talking and they are referring to the patient in third person. That is why the third person auditory hallucinations. The next is voices giving running commentary. Now I will hear auditory hallucination and it will comment on my actions or even my thoughts. For example, say I am sitting in my bedroom and I decide to go to the kitchen to have a glass of water. What I will hear is, he just got down from the bed. He just wore the slippers. Now he is slowly moving towards the kitchen. He opened the fridge door. He took out the bottle and he drank the water. It is like a running commentary is going on about my behaviors and actions. This is voices giving running commentary. And lastly, we have voices saying thoughts aloud, also called as thought echo. So whatever I think, I hear the same. Because whatever I think, the same thing is spoken by the auditory hallucination. For example, if I thought that after the class, I will go to a good restaurant and have a great meal, I will immediately hear, after the class, I will go to a good restaurant and I will have a great meal. So because I'm hearing my own thoughts, that's why it's called as thought echo. What is echo? Whatever I speak, I hear the same thing. What is thought echo? Whatever I think, I hear the same thing. The 10th one is delusional perception. Now, delusion is a disorder of thought. What is happening here is a delusion is getting attached to a normal perception. There are two steps. In the first step, there is a normal perception. Then, in the second step, a totally unrelated delusion is attached to it. For example, if I say, the color of this pointer is black, which means I am the richest man on the earth. So I am the richest man on the earth. This is a delusion of grandiosity. The color of this pen is black, of this pointer is black, is a normal perception. I have attached a delusion of grandiosity to a normal perception in a totally ununderstandable manner. There is no relation whatsoever between the color of this pen and my financial status. And that is why this connection is ununderstandable. And the last one is called as somatic passivity. Here what happens is, patient experiences certain physical sensations and blames an external agency for the same. For example, if I say that I feel some tingling sensations in my left hand, I'm having some tingling sensations in my left hand, and some intelligence agency official is throwing radio waves from another city which is causing tingling sensations in my left hand, this would be an example of somatic passivity. So these 11 are clubbed under SFRS. Now briefly, let's talk about the etiology of schizophrenia. We are still stuck at the hypothesis level. The most acceptable hypothesis is the neurotransmitter hypothesis. Earlier it was said that excessive levels of dopamine or a hyperdopaminergic state is responsible for schizophrenia. Now it has been slightly modified. Now we say excessive levels of dopamine as well as serotonin play the primary role in the development of schizophrenia. You need to remember a genetic syndrome which is called as DiGeorge syndrome, also known as villocardiofascial syndrome. Now this particular syndrome is caused by a deletion on the 22nd chromosome, and these patients, when they grow up, when they reach their adolescence or adulthood, 30% of them end up developing schizophrenia. So why is it important? Because it gives us some hint about the genetic cause or genetic nature of the causation of schizophrenia. There is something to do with the 22nd chromosome which is responsible for development of schizophrenia. So that is why this syndrome is very important, and it is often asked in the exams which particular syndrome has been found to be associated with the development of schizophrenia. Now the symptoms that we talked about till now, they were according to the historical basis. I mean, what did Schneider say about the symptoms? But when today we talk about the symptoms, we talk about entirely different groups. So the symptoms of schizophrenia can be subdivided into certain symptom groups, and let's talk about these symptom groups. First and the foremost are the positive symptoms or the psychotic symptoms. Now, if you remember the classification of psychosis versus neurosis, we said that there are two symptoms which are seen in patients with psychotic disorders. What are they? The delusions and the hallucinations. Now, what we need to remember is delusions and hallucinations, both of them respond well to medications, and they are associated with a good prognosis. In fact, once they asked this question, what is the first symptom that responds to antipsychotic treatment? The answer was hallucinations. So if there are positive symptoms, obviously there would be negative symptoms. Negative symptoms are more important as far as your exams are concerned. They are more frequently asked. So what are some of the important negative symptoms? We have got avolition. So basically, what is the meaning of this positive word and the negative word? Positive symptom means something which is beyond the normal functioning of brain. It is pathological, but beyond the normal functioning of brain. For example, brain normally does not produce delusions or hallucinations. Because of the disease process, something extra is being created, hence the positive symptom. Negative symptom is something which is usually a normal function of brain, but because of the disease process, it is getting lost. So something is being lost, hence the negative symptom. For example, avolition, loss of drive for meaningful activities. The patient does not feel like doing anything meaningful. What is meaningful? Studying, going to college, taking exams, making money, taking care of family. All these are meaningful activities. A patient with schizophrenia who has avolition does not do any of these. He just keeps lying on the bed throughout the day, does not do anything meaningful. Another negative symptom is anhedonia, inability to feel pleasure. A patient with anhedonia does not feel happy about anything. Usually the question that we ask to the patients in the real world is, we ask the family members, when a festival comes, say the Diwali comes or the Eid comes, does the patient feel happy? They'll say no, he does not seem to get impacted by any of the festivities. Affective flattening, we talked about it, lack of emotional response. Patient does not feel happy about anything. Why are negative symptoms important? First of all, they don't respond well to medications, and secondly, they are associated with poor prognosis. A very commonly asked question. The question goes something like this: which of the following patient has a bad prognosis? First, patient who is violent and aggressive. Second, patient who has delusion of persecution. Third, patient who has third person auditory hallucination. Fourth, patient who does not have any emotional response at all. Now you may be tempted to mark the option 1, the violent one, as the answer, but the real answer is option 4, the negative symptoms. The third group of symptoms are disorganization symptoms, which usually include disorganized behavior, which means the socially inappropriate behavior. Say the patient goes into the public and starts removing his clothes. This is a disorganized behavior. Or the patient goes out and starts eating things that are lying on the ground. This is a socially inappropriate behavior. Also, disorganization of thought. We talked about it. In simple words, the formal thought disorders. So this is the third group of symptoms, disorganization symptom. And last and perhaps the most important group of symptoms include the motor symptoms. Now there are various terms used to describe the motor symptoms, which include catatonic symptoms and the symptoms of conation. They have asked in the exams, conation refers to, the answer is motor symptoms. So there are a couple of motor symptoms which are often asked in the exams. Let's go through them one by one. The first one is stupor. What is stupor? It is a state of extreme immobility and minimal responsiveness. The patient does not move and does not respond normally. He responds only to extremely painful stimuli. So in fact, AIMS had asked this question, akinesis and mutism is seen in. The answer was stupor. Akinesis can be considered as a synonym for immobility, and mutism of course will result because of minimal responsiveness. The answer was stupor. Also remember, usually in stupor the eyes are open. In comparison, usually in coma the eyes are closed. The second motor symptom is posturing, sometimes equated with catalepsy. Strictly speaking, there is a slight difference in posturing and catalepsy, but at your stage just remember posturing or catalepsy. So what is posturing? Patient maintains a posture for long periods of time. Any posture, patient will stay in that for long periods of time. That is why it's called as posturing. The third one is vexiflexibility. Now what is vexiflexibility? So what happens is, say I am the patient and you are my doctor, and you are doing a passive movement on me. Say you are doing adduction at my shoulder joint. Now when you start the adduction, initially there would be some resistance, and then the resistance would become less and you would be able to move it easily. While you are doing this movement, you will feel a vex kind of resistance. While making this passive movement, you will feel a vex kind of resistance. That is why it's called as vexiflexibility. Why? Because the resistance that you felt in this entire movement, initial resistance followed by wax-like resistance, is the same resistance that you feel if you try to break a wax candle. If you break a wax candle, initially there is resistance, and then once it breaks, it becomes easier, and now you feel that vexy feeling while moving it. So because the doctor is having the same feeling while moving the patient, hence the term vexiflexibility has been used. In very simple words, patient becomes as flexible as wax during a passive movement. This statement is not entirely correct, but good enough to get your MCQ right. The next is automatic obedience. Automatic obedience is a state of excessive cooperation despite unpleasant consequences. So patient will follow all commands of yours even if the consequences of that are not so pleasant. A state of extreme cooperation is automatic obedience. The opposite of automatic obedience is negativism. Here, the patient is not following any of the commands without any reason. For example, you ask the patient, stand up, I want to examine you. Patient refuses. You ask the patient, show me your tongue. He refuses. This is negativism. Then we have got echolalia and echopraxia. Echolalia is the repetition of examiner's speech. Echopraxia is mimicking of the examiner's behavior. For example, when you stand up, patient also stands up. If you start scratching your forehead, patient also starts scratching his forehead. And then there is grimacing. Grimacing is maintenance of an odd facial expression. Grimacing is something like this. Patient does this. This is grimacing. Now there are three motor symptoms that are pretty important: stereotypy, mannerism, and perseveration. Last year exam question. Now if you look at these three definitions, all of them are abnormal motor movements. Stereotypy is spontaneous, that is, patient does it himself, not in response to any command. Spontaneous repetition of odd and purposeless movement. For example, patient does something like this. This is a stereotypy. He is doing it himself, and this movement does not serve any purpose. Mannerism, on the other hand, is also spontaneous, but it is repetition of semi-purposeful movement, which is done in an exaggerated manner. For example, if the patient does like this, now this movement has got some purpose. The purpose is to fix the hair, right? But you are doing it in an exaggerated manner. Third is perseveration. Now it is not spontaneous. It is in response to a command. It is an induced movement, which is repeated beyond the point of relevance. For example, you ask the patient, show me your tongue. Patient shows you his tongue. Then you say, okay, now stand up. Patient again shows you the tongue. Then you say, okay, now sit on that table. Patient again shows you the tongue. Now, despite the change in the command, patient is continuing with the original response. This is perseveration. Continuation of the same response, repetition of the same response beyond the point of relevance. Let's talk about suicide and schizophrenia. Now, they have asked a couple of questions from this topic in the last 2-3 years. Let's remember 2-3 things. First of all, the rate that has been usually accepted is 10%. Traditionally, we say the suicide rate in schizophrenia is 10%. However, in the DSM-5, it says that the suicide rate in schizophrenia is 5 to 6%. So remember both the figures. If they specifically ask about DSM, then 5 to 6%. Otherwise, 10% is an acceptable figure. Two more questions. Suicide is the most common cause of premature death in schizophrenia, and suicide is the most common cause of unnatural death in schizophrenia. Both things. Also remember that many times when the patient with schizophrenia is improving, the suicide risk may actually become higher. Many times during the improvement stage, patient may commit suicide. Of course, when the symptoms have worsened, if he is having a lot of auditory hallucinations, especially command hallucinations. Command hallucinations means when the hallucinatory voice is giving some command. Say the voice is saying jump from the roof, jump from the roof. That increases the suicide risk. So increase in the symptoms, command hallucinations, after admission, sometimes in the initial period of recovery, all these times are when the suicide rate may actually go up. Let's talk about the treatment of schizophrenia. Now, the treatment is still focused on the neurotransmitter hypothesis. We know that excessive dopamine causes schizophrenia. The earlier hypothesis, excessive dopamine and serotonin causes schizophrenia, the recent hypothesis. So the treatment, which is primarily the antipsychotics, they usually work on these hypotheses. So we have got two main categories of antipsychotics. We have got the typical antipsychotic or the first generation antipsychotic, and we have got the atypical antipsychotic or the second generation antipsychotics. Now, what are the differences between these two? First is the main mechanism of action. Typicals mostly have a dopamine antagonism. D2 antagonist action is their primary action. Atypical are also D2 antagonists, but they are also antagonist at 5-HT2, which is a serotonin receptor. Second difference clinically, typicals usually are effective only against the positive symptoms, whereas atypicals are effective primarily against positive symptoms only, but at least partially also against the negative symptoms. So remember, both typicals and atypicals primarily act against the positive symptoms, but atypicals at least have some response against the negative symptoms too. Then the side effect difference. The typicals are more commonly associated with the extrapyramidal side effects, atypicals lesser incidence. But when we talk about the metabolic side effects, the tables get turned. Typicals have lesser chances of metabolic side effects, atypicals have more chances of metabolic side effects. Alright, let's talk about some important extrapyramidal side effects. Now, this is a very important question. Very frequently they ask about these side effects. So what all side effects are considered or included under the bigger rubric of EPS? Now, the most or the earliest side effect that can follow the use of an antipsychotic is acute dystonia. Usually more commonly seen with typical antipsychotics, and more commonly seen if the antipsychotics is given by a parenteral route. Intramuscular injection or IV method is rarely used, but if it is given parenterally, the chances of acute dystonia are more or higher. So acute dystonia is sudden contraction of a muscle group. It could be sternocleidomastoid, it could be jaw, and one of the particularly interesting presentation of dystonia is sudden uprolling of eyeballs, also called as oculovariccrisis. What you see is you give an injection and suddenly the eyeballs would go up. And it is very frightening to see, but it's not that big a deal. Just give an injection of anticholinergic and the things will go back to normal. So the treatment of choice for acute dystonia is use of parenteral anticholinergics like promethazine. IM promethazine fixes most of these problems. The most common side effect of antipsychotics is akathisia. Now, acute akathisia is basically the patient has a feeling of restlessness. He says, the doctor, I feel a lot of restlessness in my legs. And you can also observe the signs of restlessness. Patient is very fidgety. He'll keep on moving. He would not be able to stand still. He will be fidgety. So both things put together, objective plus subjective signs, is called as acute akathisia. Most common side effect, the drug of choice for acute akathisia is beta blocker like propranolol. You can also use benzodiazepines and you can also use anticholinergics. Then we have got the drug-induced Parkinsonism. Now the antipsychotics are dopamine antagonists. Obviously they will cause Parkinsonian features. We see the classical triad, tremors, rigidity, bradykinesia. How do you treat it? By using anticholinergics. If you are using antipsychotics for too long a time, what will happen is the dopamine receptors, if they are blocked for too long a time, they may become super sensitive. And the super sensitivity of dopamine receptors may result in a side effect called as tardive dyskinesia. The term tardive refers to long-term. Dyskinesia obviously means abnormalities of movement. Ames had asked this question, what is the pathophysiology behind it? It is super sensitivity of dopamine receptors. So patient may show involuntary movements. It may be of tongue, also called as rabbit syndrome. The patient may bring the tongue out and in again and again in the form of like what a rabbit does, or there might be jaw movements, chewing movements, or there may be movements of extremities. Patient may have weird abnormal movements of extremities. All this is called as tardive dyskinesia. Usually the treatment is shift the antipsychotics. If the patient is on a typical, shift it to atypical, and you can also use dopamine depleters like tetrabenazine. The most important and the most dangerous side effect, lethal side effect of antipsychotics is NMS, neuroleptic malignant syndrome, characterized by a triad. We have got elevated temperature, we have got muscle rigidity, there is muscle loss, muscle damage, which results in increased creatine phosphokinase, increased CPK. The muscle damage can also result in myoglobinuria, which can cause ARF, acute renal failure, which is the most common cause of death in these patients. So what is the drug of choice for NMS? It is dantrolene. Some other drugs like dopamine agonists, like amantadine and bromocriptine, can also be used. All these extrapyramidal side effects are more commonly seen with typical antipsychotics, less commonly seen with atypical antipsychotics. All right. Apart from the EPS, there can also be endocrine side effects. We know that dopamine is an inhibitor of prolactin. When we use antipsychotics, which has got dopamine antagonism, it can result in hyperprolactinemia, which can cause side effects, which can cause abnormal manifestations. So hyperprolactinemia in females can present with menstrual abnormalities, galactorrhea, and decreased libido. In males, it usually presents with libido disturbances of libido. The endocrine side effects are also more common as a group in typical antipsychotics in comparison to atypical antipsychotics, but two atypical antipsychotics, particularly risperidone and amisulpride, they have been associated with higher incidence of endocrine side effects. Then metabolic side effects like weight gain, dyslipidemia, increased sugar levels, all of them are more common with the atypical antipsychotics in comparison to typical antipsychotics. A couple of questions. The antipsychotic associated with maximum weight gain is clozapine. The antipsychotic associated with minimum EPS is clozapine. The only antipsychotic with anti-suicide property is clozapine. The typical antipsychotic associated with minimum EPS is thioridazine. So all these 4 MCQs have been asked in exams. Now, important clinical questions. The first question is the duration of treatment. For how long should we continue with the antipsychotics? The answer is simple. If it was a first episode, continue antipsychotics for 1 to 2 years. If you have to pick one figure, it would be 2 years. And for more than one episode, 5 years or more. If a patient is having a repetitive episode, maybe lifelong treatment may be required. Second question, what is TRS? Treatment resistant schizophrenia. So if a patient does not respond to 2 different antipsychotic trials, patient comes with schizophrenia, you start him on an antipsychotic, give it in an adequate dosage for at least 4 to 6 weeks, but you don't find a result, you switch the patient to some other antipsychotic, again give it for 4 to 6 weeks, no results. Now you say that patient has TRS, treatment resistant schizophrenia. And out of these 2 antipsychotics, at least one should be an atypical antipsychotic. And what is the drug of choice? Clozapine. Third clinical question. There's a patient who has schizophrenia. The insight is not there. The patient does not accept that he has schizophrenia and is not compliant with treatment, does not take the medications regularly. What can you do to improve the compliance? The answer is we can use the depot antipsychotics. We can take the dosage for the entire month and give it in the form of parenteral injection. There are intramuscular injections available for a lot of antipsychotics. They can be used in patients who are not compliant with the treatment. So depot preparations of long-acting injectable antipsychotics given by intramuscular route. These are the 3 clinical questions typically asked in the exams. Now let's talk about the other psychiatric disorders. So we talked about schizophrenia, but we did not discuss the duration criteria required for schizophrenia. The duration criteria depends upon the classificator system being used. ICD says that the symptoms must continue for more than 1 month to make a diagnosis of schizophrenia. If we have psychotic symptoms continuing for less than 1 month, then we make a diagnosis of acute and transient psychotic disorder. On the other hand, DSM says that symptoms, the total duration of illness should be more than 6 months before we can make a diagnosis of schizophrenia. For 1 to 6 months duration, the diagnosis is schizophreniform disorder. For less than 1 month, the diagnosis is brief psychotic disorder. And all these disorders, they are psychotic disorders and they are treated using antipsychotics. Now, say a patient comes to you, the primary symptom in this patient is a particular delusion. Say the delusion is the delusion of infidelity. The patient thinks that his wife is having an affair with a neighbor. And after some time, the delusion further increases. He starts saying that the wife is having an affair with the neighbor. and with the landlord and with the security guard. There are no hallucinations. The patient continues to go to the office normally. He is performing well in the office. There are no negative symptoms. What is the diagnosis? So the diagnosis is delusional disorder. If the disorder is characterized by a single or a set of related delusions, the diagnosis goes towards delusional disorder. Usually in these patients, hallucinations are not there. If rarely the hallucinations are there, the content is directly related to the content of delusion. Say in this patient, if he is having hallucination once in a while, rarely, if he hears a voice, the voice will also say, wife having an affair. The content remains the same. And the most important hint that they give you for delusional disorder is the functioning of the patient is disturbed only in the domain that is directly affected by the delusion. For example, this patient who has delusion of infidelity, the functioning in the personal domain is impacted, but when he goes to office, he is fine, he is normal. This is a hint they always give. Look for that hint in the question. How would you treat delusional disorder? It's a psychotic disorder. We treat it with antipsychotics. If you can see this image, what is this sign? Stupor, posturing, ambitendency, negativism. So you can see that a patient is sitting on a chair in a particular posture. Obviously, it is posturing. What is ambitendency? Ambitendency is inability to decide a particular motor action. What does it mean? Say somebody has ambitendency and you bring your hand forward to shake hands with them. What will they do? They'll bring their hand forward, then they will take it back. Then they will bring it forward, then they will take it back. They are not able to decide, should I shake the hand or should I not shake the hand? This inability to decide the motor action is called as ambitendency. And what is the diagnosis here? Capgras or Frigoli? This is of course Frigoli syndrome. The patient is believing that the person can change his face by putting a mask and that he can change multiple faces by putting different masks. This description is totally in sync with the Frigoli syndrome. So this was about the chapter of schizophrenia. Alright students, let's talk about the next chapter, which is mood disorders. We'll start with the first topic, which obviously is depression. Now, if the examiner asks you which is the most common psychiatric disorder in India, the answer would be depression. Recently, NIMHANS conducted a study on the Indian population and they found out that the most common psychiatric disorder in India is depression. But the studies that have been done worldwide, they say that the most common psychiatric disorder worldwide they are anxiety disorders. So if the examiner asks you specifically about India, the answer is depression. But if they ask you about the world, the answer is anxiety disorders. Now, anxiety disorders are a group of disorders. If the examiner asks you about the individual psychiatric disorder, which is most common worldwide, then the answer becomes specific phobia. We will talk about these points again when we talk about the anxiety disorders in the next chapter. Now, depression is more common in females. It is twice as prevalent in females as it is in males. And depression is usually seen in the middle ages. So, a commonly asked question is, which of the population groups is most vulnerable to development of depression? The answer becomes middle-aged females. Now, two more questions from the epidemiology. If we talk about the DALYs means disability adjusted life years. When we talk about the DALYs and we say which psychiatric disorder is associated with maximum DALYs, then the answer becomes depression. But if we talk about all the disorders, all the medical disorders, and then we ask which of the medical disorder is projected to be responsible for maximum DALYs by 2020, this is a question, which of the medical disorder is predicted to be associated with maximum DALYs by 2020, the answer is ischemic heart disease followed by depression. So by 2020, depression would be the reason for or cause of second highest DALYs amongst all the psychiatric disorders. This question has been asked by multiple exams in the last years. Please remember this point. Alright, let's talk about the symptoms of depression. Now, the symptoms of depression can be remembered, can be memorized by using this mnemonic SIGE caps. So what are the symptoms? The first and the foremost symptom, of course, is sadness of mood or depressed mood. The patient feels sad all the time. Then we have loss of interest or decreased interest. The patient does not feel like doing anything, does not enjoy anything. Then we have guilt, excessive guilt feelings or feelings of worthlessness. Patient feels that I am not worthy of anything, I do not have any qualities, and feels guilty about everything. So this is excessive guilt and lack of worth. Then we have energy symptoms. The patient feels very tired, gets tired very easily, there is a lot of fatigue. Concentration. The patient is not able to concentrate on any task. If he is a student, he is not able to concentrate on the studies. If he is doing a job, he is not able to concentrate on the job. And the decision making is also delayed because of the lack of concentration. Now, appetite is usually lost. And when the appetite is lost, there is resultant weight loss. But in a small minority of cases, the appetite may actually increase, resulting in weight gain. Then we have got a symptom of psychomotor agitation or retardation. Now, if you look at this word psychomotor, it basically means the motor activity which is caused by the psychological causes, or motor activity influenced by psychological causes, psychomotor. So, usually the patient has restlessness. The patient may be agitated, that would be called as psychomotor agitation, or the patient's motor activity may significantly decrease, called as psychomotor retardation. The patient may just curl up, may just lie down on the bed and may not move at all. This would be called as psychomotor retardation. We have suicidal thoughts. The patient may have thoughts about death, about committing suicide. And lastly, the sleep disturbances. Now, usually there is insomnia. The sleep decreases, and the characteristic type of insomnia in patients with depression is early morning insomnia. What is early morning insomnia? Say the patient's usual waking up time is 8 o'clock in the morning. Now he will start waking up before 6 o'clock. So the waking up time kind of shifts by more than 2 hours. More than 2 hours prior to the usual time of getting up. This is called as early morning insomnia. It is characteristically seen in patients with depression. In some cases, the sleep may actually go up. It may be hypersomnia. Now, there are certain special symptoms that patients may present with, and these are called as specifiers. A patient with depression may also develop hallucinations or delusions. If that happens, we make a diagnosis of depression with psychotic symptoms or depression with psychotic features. Now, always remember, if a patient has a psychotic feature in the form of either delusion or hallucination, we will have to add antipsychotics to the treatment of this patient. You always add antipsychotics to the regimen if there are psychotic symptoms. The second specifier, which has been asked by especially AIMS exam in the last 2-3 years a lot, is the presence of atypical features. So typically what happens in depression? The appetite is lost, the weight is lost, and the sleep decreases. In atypical depression, the reverse will happen. So we have increased appetite that results in weight gain and hypersomnia. Apart from this, second important thing is the mood reactivity is present in atypical depression. What does mood reactivity means? So say I'm having atypical depression and I'm usually sad, but if something good happens in my life, say an old friend calls me, or say I get a raise in my job, these things will cheer me up. These things will make me happy, which shows that the mood is still capable of showing response to the external environment. Third thing, there is a characteristic feature of leaden paralysis in patients with atypical depression. So if you look at this word leaden and paralysis, what happens is the patient with leaden paralysis has a subjective feeling. There's a subjective feeling of heaviness of limbs. Patient feels as if the limbs have become very heavy. And because they have become heavy, they feel heavy, patient finds it difficult to move them. So because of the feeling of heaviness, the term leaden, and because of the difficulty in moving them, the term paralysis. So leaden paralysis. In reality, there is no change in the weight of the limbs. There is no paralysis per se. It's all a subjective experience. Now, there has been a long-term tendency of extreme sensitivity to interpersonal rejection. What is interpersonal rejection? Some people are very sensitive if they feel that the other person is not liking them, the other person is criticizing them, or the other person is rejecting them, they have an extreme response, or they become very disturbed by that. This is called as extreme sensitivity to interpersonal rejection. So the patients who have atypical depression usually have a tendency of extreme sensitivity to interpersonal rejection. Now, the last bullet is what they ask in the exams. Please remember this, put this in your mind, put this in your brain, long-term memory, that patients with atypical depression, they respond better to selective serotonin reuptake inhibitors and MAO inhibitors, and not so better, and they don't respond so well to TCAs. Tricyclic antidepressants are not so effective. Now, another specifier of depression is what we call as depression with melancholic features, or sometimes referred to as involutional melancholia. Usually melancholic depression is seen in older people, older individuals. If you look closely at the symptoms of melancholia, involutional melancholia, they are kind of opposite of what the symptoms of atypical depression were. For example, in atypical depression we said that the biological features are reversed. Here the biological features are pretty prominent. There are significant features. There is significant anorexia, significant weight loss, and significant insomnia. Characteristic early morning insomnia is present here. Then second point, there we said that mood reactivity is present. Here there is complete lack of mood reactivity. No matter what happens, nothing cheers up the person. Third, the patients with melancholic depression, they have a very distinct quality of mood. In fact, this was a question of the recent NEET exam or AIMS exam, but it was asked this year only. The depression of, or the depressed mood of a patient with involutional melancholia has a characteristic quality. The patient says it feels really bad, they feel really horrible, and sometimes we use the word they feel miserable. So this is a distinct quality of mood in patients with involutional melancholia. And typically we see that these patients have the worst feeling in the morning. When they get up, the mood is at its worst, and as the day progresses, it tends to get slightly better. These patients have excessive feelings of guilt. The psychomotor agitation or retardation may be significant. There's a typo here. It's not psychomotor aviation, it's psychomotor agitation. And so these are the features of melancholic depression. Also remember that these patients have higher chances of developing psychotic features, and the possibility of suicide attempt and completed suicide are also higher than the other forms of depression. Please remember both these points. Let's talk about the etiology of depression. Now, we are still talking about the neurotransmitter disturbances. We all know that classically we say that depression is caused by deficiency of serotonin, but now the hypothesis has been widened. We say not only serotonin, but all the monoamines, serotonin, norepinephrine, as well as dopamine are involved in the development of depression. For your exams, more important is the psychological theory of depression, and the most important psychological theory of depression is cognitive theory of depression, which was given by a psychiatrist named Aaron Beck. Now perhaps this is the most important point of this chapter, very frequently asked in the exams. So what is the meaning of cognitive theory? Cognition, if you remember, we said in the first chapter, cognition basically is equal to, or it can be used for describing the thoughts. Now the cognitive theory of depression says that the maintenance of depression, the depressive symptoms continue because patient starts developing negative automatic thoughts. The patient keeps on getting negative thoughts about everything and anything, and these negative thoughts tend to continue this state of depression. So Aaron Beck gave this theory, and Aaron Beck said that out of all the negative thoughts, there are 3 negative thoughts which are of paramount importance, which are of particular significance, and these 3 thoughts put together are called as Beck's cognitive triad. 3 thoughts, that's why the triad. So what are these 3 thoughts? The first one is negative view of self. The patient has negative thoughts about himself. He thinks, I am useless, I don't have any quality. Also called as idea of worthlessness, I am worthless. Negative view of environment, that the conditions or the world is hostile, people are not helpful, and I am feeling helpless in this world. Ideas of helplessness. and negative view of future, that the future is going to be as dark as the present is. There is no hope in the future either. So put together, they are called as ideas of hopelessness, helplessness, and worthlessness. Out of these three, ideas of hopelessness are of more importance because they have been found to be associated with increased risk for suicide. If somebody has ideas of hopelessness, the suicide risk is higher, and it's pretty understandable. If I think that life is bad today, and if I also think that future is going to be as dark, then obviously I might get a thought that future is not gonna get better anyhow, so there is no point living this life, and I might think about suicide. So remember these three Beck's cognitive triad symptoms. All right, let's jump to the treatment. So the first thing, of course, we can use medications, antidepressants. Now there are multiple categories of antidepressants. We have got SSRIs, selective serotonin reuptake inhibitors. We have got SNRIs, serotonin, norepinephrine reuptake inhibitors. We have got TCAs, tricyclic antidepressants. We have got MAO inhibitors, monoamine oxidase inhibitors, and rest of the newer antidepressants can be clubbed together under the rubric of atypical antidepressants. Couple of things we must remember. The most commonly used antidepressant, or the first antidepressant that is usually used in a patient with depression, is SSRI. We use a SSRI like, say, escitalopram. Why so? It's not because escitalopram or other SSRIs are more efficient, or they are more potent, or they have an earlier onset of action. None of these are true. We use SSRIs as the first antidepressant because the side effect profile of SSRIs is better than the other types of antidepressants. So remember that antidepressants are chosen on the basis of side effect profile and nothing else. Now, in the last 3-4 years, a lot of examiners have been asking about TCA toxicity, tricyclic antidepressant toxicity. So let's spend some minutes on this topic. A favorite topic of APES examiner for some reason. TCAs nowadays are not used that frequently, not used that commonly, because they are not very safe drugs. They have got a lot of side effects, and more importantly, if a person does overdosages, they can be fatal, they can be lethal. So a person who consumes excessive amount of a TCA may present with these symptoms. There may be hypotension, there may be tachycardia, the sensorium may get altered, and most importantly, there may be respiratory depression and seizures. Now, there are significant changes in the ECG also. If you look at the ECG, most of the questions are on the ECG changes. The most important thing is the QRS interval may get prolonged. The QRS interval may get prolonged. There may be prolongation of PR as well as QT interval, and there may be right axis deviation. Along with that, TCAs we know have anticholinergic side effects, so there may be dry mouth, there may be blurred vision, and metabolic acidosis may also develop in these patients. Now, the examiners ask you, what would you do if you see that a patient has developed TCA toxicity? Now, TCA toxicity responds best to intravenous sodium bicarbonate, and we use intravenous sodium bicarbonate only when the QRS interval has crossed 100 milliseconds. If the QRS interval is more than 100 milliseconds, only in that case we use sodium bicarbonate. Remember, TCA toxicity, they would often give you a question like, an elderly male who has been taking treatment for depression comes to the emergency and he appears confused, there is decreased blood pressure, and when the ECG was done, we find QRS interval prolongation. Which of the following antidepressant is he most likely to be using? And then they will give escitalopram, they may give imipramine, they may give bupropion, they may give mirtazapine. We know that these are the toxicity signs of a TCA like imipramine. Another common question that these examiners are asking nowadays are about the side effects of the SSRIs. For some reason, AIMS has asked this question in consecutive years. So what are the SSRI side effects? Now, the most common side effects, of course, are the GI side effects, nausea, vomiting, acidity, all those things are very common. Apart from these, sexual dysfunction, So if somebody uses SSRI over a longer period of time, so the most common side effect to develop in the longer duration, if the SSRI is being used for a longer duration of time, is one of the sexual dysfunctions. So there may be decreased libido, there may be erectile dysfunction, or there may be delaying of ejaculation. All of these may be seen. This is about the sexual dysfunction. Apart from the GI side effects, which are the most common side effects in the shorter term, and the sexual dysfunction, which is the most common side effect in the longer term, there are certain other specific side effects such as sweating and vivid dreams. The patient may see very elaborate dreams and may get up in the morning and he may say that, doctor, my mind kept on working the entire night. I kept on seeing dreams, and after waking up I don't feel fresh. This is called as vivid dreams. Weight gain can be there, long-term side effect of all the antidepressants for that matter. They can also be seen with SSRIs. Now, recently a question came on the discontinuation symptoms. So what happens is, you cannot suddenly stop an antidepressant. If a patient has been consuming an antidepressant for some period of time, and if he suddenly stops it, he may feel certain symptoms which are called as discontinuation symptoms. Now, venlafaxine, which is a SNRI, it is the most common antidepressant associated with discontinuation symptom. This question was asked in the recent AIMS exam. And apart from venlafaxine, some other SSRIs, especially short-acting SSRIs like paroxetine and fluvoxamine, have also been associated with discontinuation symptoms. What are the symptoms? The patient has a flu-like syndrome. Flu-like symptoms are there. There may be nausea, and special importance must be given to the side effects of Special importance must be given to the symptoms of agitation and anxiety. When you stop SSRI suddenly, when you stop SNRI suddenly, patient may become very agitated or restless, and of course insomnia. So if somebody has been using antidepressants for some time, you just can't stop it like that. You have to taper it down first, and then you can stop it. Apart from antidepressants, the other modality that can be used is electroconvulsive therapy, the shock therapy as we call it. Now remember, in the exam, if they give you a patient who has symptoms of depression and then they give history of increased suicidal risk, how would you know that the suicide risk is increased? Either they will give you history of a recent suicide attempt, or they will give you history of frequent suicidal thoughts. So a patient with depression, increased suicide risk, and they ask you what is the best treatment in this scenario. Close your eyes and choose the option of electroconvulsive therapy. Electroconvulsive therapy is the most effective treatment in patients of depression who have suicide risk. ECT is perhaps the only method which has a very fast onset of action. If a patient has depression and you start him on an antidepressant, it will take weeks before he starts showing any impact, but ECT almost starts working immediately. That is why in life-threatening situations where the suicide risk is high, we do not take a risk, we go for ECTs. So depression with high suicide risk, and also depression with stupor. If the patient has developed stupor along with depression, again we need something that will work immediately, and that something more often than not is electroconvulsive therapy. Apart from these biological methods, we can also use psychological methods, what we call as counseling. Now, counseling is a layman term. The right medical term is psychotherapy. Psychotherapy means therapy by psychological means. If you remember, we said that the psychological theory of depression is cognitive theory of depression, which says negative thoughts result in development or maintenance of depression. So if negative thoughts are causing depression, how can we treat depression? If we can remove or reverse the negative thoughts. And that is what we attempt when we do cognitive behavioral therapy. The most effective and evidence-based treatment, psychological treatment of depression is cognitive behavioral therapy. Let's talk about the other mood disorder, which is bipolar disorder. Now, the term bipolar itself tells you that the symptoms are going on both the poles, the pole of mania and the pole of depression. So patient may develop episodes of mania and the patient may develop episodes of depression. Now, there are two primary types of bipolar disorder, and this has been an update in ICD-11. till ICD-10, bipolar 1 and bipolar 2 were not included in the formal classification of ICD. In the ICD-11, for the first time, ICD formally classifies bipolar disorder into bipolar 1 and bipolar 2. What is the difference? A patient with bipolar 1 will have episodes of mania as well as depression, whereas a patient with bipolar 2 will never have an episode of mania per se. He will have episodes of depression and he will have episodes of hypomania. Hypomania is a milder form of mania, but he will never have a full-fledged episode of depression. So let's spend some time talking about the symptoms of mania. What are the symptoms of mania? Of course, the first symptom is elevated mood. The patient is euphoric, very happy, or he may be irritable. The mnemonic of manic symptoms goes as MyAsia Fast GDP. M stands for mood elevation. A stands for increased activity levels. The patient keeps on doing something or other throughout the day. The level of activity goes couple of notches higher. Then we have flight of ideas. If you remember the first chapter, we talked about flight of ideas and we said that flight of ideas is a feature of mania. For some reasons, activity level, increased activity level is again put as a criteria in DSM. So again, we have abnormally increased levels of activity or increased levels of energy. Now this one is important, sleep changes. In mania, there is decreased need for sleep, which means that a patient may require only 1 hour of sleep in 24 hours and that might be enough to refresh him. He sleeps for 1 hour in the entire 24 hours and he is good to go. He is again feeling energetic. This is called as decreased need for sleep. If you look at a patient with depression, he also has decreased sleep. He is not able to sleep, but he complains bitterly about it, that I am not able to sleep. But this guy, he is not able to sleep. He is not sleeping for more than 1 hour, but he is very happy with it. He is saying that anyhow, I have got so many things to do that I don't have time for sleeping and I am good to go. Talkativeness. There is increased talkativeness. Patient speaks a lot. Then we have grandiose ideas or increased self-esteem. Patient may make big claims like, I know a lot of politicians. I am a very powerful guy. My mind works really good. All these big ideas, the self-esteem may go up. Now, despite all these things, the output is really poor. The patient has a lot of energy, doing a lot of activity, but the output is really poor. Why? Patient is very distractible. Say a medical student develops mania. He gets up in the morning and he says, by tonight I will finish the entire Harrison's. And then he opens Harrison, start reading the page 1, but after 5 minutes, the thought comes in the mind that I should finish surgery first. So he closes the Harrison's, opens the surgery book and starts reading that. After some time, the thought comes, let me go to psychiatry. So though he's having a lot of energy levels, he's not able to achieve anything because he's jumping from one thing to another. He is very distractible. And lastly, there is increased involvement in activities which may have painful consequences. Now the patient is not judging himself properly. Say a patient is thinking that I am really powerful. He thinks that I can beat 10 people all by myself. And say he actually goes and picks a fight with 10 people. Now what will happen? He may get beaten and he may come back. Now this is an activity with potentially painful consequence. So patient keeps on exposing himself to things where the consequences may be not really good. So these are the symptoms of mania. And apart from these main symptoms, patient may again develop psychotic symptoms like delusions or hallucinations. The duration criteria for mania is 7 days. If you talk about hypomania, now a patient with hypomania will have all the same symptoms, the exact same symptoms. The only difference is the symptoms of hypomania are not that severe. The severity is less, and when the severity is less, it results in lesser amount of dysfunction of life. And also the duration criteria, instead of 7 days, it is 4 days. All right. Let's talk about the treatment of bipolar disorder. Now, this is an important topic. If they ask you a question from bipolar disorder, it's quite likely that it would come from the treatment part only. Now, the treatment of bipolar disorder basically depends upon the stage in which patient is coming to you. Patient may come to you in acute mania. Patient may come to you in acute depression, or patient may come to you for prophylaxis. He is not having any episode as of now, but he wants to ensure that there are no future episodes. So the treatment will differ accordingly. First of all, let's talk about acute mania. Now, there are three groups of medications that are usually used. We can use the mood stabilizers, we can use the antipsychotics, and we can use the benzodiazepines. If they give you a clinical vignette where they describe about a patient with mania and they ask you what is the best treatment available here, or what is the best treatment that can be given to this patient, if one of the options is a combination of mood stabilizer with antipsychotic, that will be the best answer. For the treatment of acute mania, a combination of mood stabilizer like lithium or valproate along with an antipsychotic like risperidone or olanzapine would be the most effective treatment. But usually they don't give this option in the exams. They give you questions like, what is the drug of choice for acute mania? Option 1 lithium, option 2 valproate, option 3 haloperidol, option 4 diazepam. So if you are forced to pick one, you will always pick antipsychotics. The drug of choice for acute mania is antipsychotics. I know that there is some controversy about this thing, but trust me, the better answer is antipsychotics. If you look at the guidelines, the British guidelines, they clearly say that for acute mania, antipsychotics are the preferred drug. If the question is simply what is the drug of choice for severe mania, again the answer is antipsychotics. If they ask you, if they give you a history about a female, a pregnant female, and then they say that in the pregnancy she develops mania, what is the best drug that can be given to her? And the options are lithium, valproate, haloperidol, say lamotrigine. The answer again is antipsychotic. Even in pregnancy, the best option is use of antipsychotics. If we talk about the mood stabilizers, the lithium, valproate, and the carbamazepine, and their use in pregnancy, so can we use them? Well, all the mood stabilizers, all the three major mood stabilizers, lithium, valproate, as well as carbamazepine, all of them are teratogenic. Lithium, we all of us know that it causes Epstein's anomaly. It is a commonly asked question that lithium can cause Epstein's anomaly. Valproate and carbamazepine can cause NTD, neural tube defects. But if you have to pick between lithium and valproate, you would still pick lithium, because the prevalence of Epstein's anomaly in the children of the patient who use lithium during pregnancy is still very less in comparison to the prevalence of NTD in the babies whose mother used valproate during the pregnancy. So if you have to avoid one mood stabilizer in pregnancy, that would be valproate. We never ever use valproate in pregnancy unless there is some real indication for it, because the prevalence or the chances of the baby developing NTD is very high. Alright, so it says valproate is the most teratogenic, can cause NTD, lithium can cause Epstein's anomaly, but the chances are much lesser. Now let's talk about the acute depression treatment. Well, usually we use mood stabilizers, and the mood stabilizers that we use include lithium and lamotrigine. One of these two, lithium or lamotrigine. Sometimes even the combinations are used. A couple of questions. Which is the only mood stabilizer that has got anti-suicide properties? The answer is lithium. Which is the only antipsychotic that has got anti-suicide properties? The answer is clozapine. About lamotrigine, an important question is, all the mood stabilizers that are available, they have better anti-manic effect in comparison to antidepressant effect. All the mood stabilizers have better anti-manic effect than antidepressant effect, except for lamotrigine, which has a better antidepressant effect than anti-manic effect. What does it mean? So all the mood stabilizers, they are effective against mania also and depression also, but they are more effective when they are given for manic patients, not so effective when they are given for patients in depression. But for lamotrigine, the reverse is true. Lamotrigine is more effective when it is given in a patient who is having depression, not so effective when it is given in a patient who is having mania. As far as the prophylaxis is concerned, usually we use mood stabilizers like lithium or valproate. Now, apart from these medications, the psychotherapy that we use in bipolar disorder is psychoeducation. What is psychoeducation? Educating the patient psychologically. Basically what you do is you tell the patient that, look, you have got bipolar disorder, there would be episodes of mania and depression. If you continue on these medications, the chances of these episodes goes down significantly. These are the possible side effects. This is what we can do about it. So when you give education to the patient, the compliance with the treatment increases. The compliance with the treatment improves. This is the AIMS question. If a patient is not having good compliance, use psychoeducation. Let's talk about suicide. The first thing, the suicide rate in India is 10.6 per lakh of population, and the most common method of committing suicide in India is hanging followed by use of poisons. Now, what is parasuicide? So sometimes what you will find is patient may self-injure. Patient may injure themselves, but they do not have an intention of killing themselves. Say a patient is slashing the wrist. Now she is harming herself, but she does not want to kill herself. This would be called as parasuicide. So self-harming behavior without the intention of killing self is parasuicide, or sometimes referred to as deliberate self-harm. What is paradoxical suicide? Last year question. Now what happens is, say there's a patient who has got depressive symptoms. He is having suicidal thoughts, but at the same time there is so lack of energy. He is feeling so tired, so fatigued, that despite having suicidal thoughts, he is too tired or is too physically weak to even carry out the suicidal thoughts or work or act upon those suicidal thoughts. So we reach a stage where the person is having suicidal thoughts, but he does not act upon those because he is feeling too tired weakly even to attempt suicide. Now you start this patient on an antidepressant. The patient starts to improve. Now what happens is the energy levels improve first and the suicidal thoughts become better later. So there is a phase, a window period where the energy levels have improved, but the patient is still having suicidal thoughts. So in this period, the patient is more likely to attempt suicide. So this is a paradox here, that patient is not attempting suicide or not committing suicide when he was depressed, but he's committed suicide or attempted suicide when he started to improve. This is called as paradoxical suicide. The most common cause of suicide is, of course, depression. Now, this is a very important topic. What are the risk factors for suicide? So, who is most likely to attempt suicide in future? Someone who has attempted suicide in the past. The most important risk factor for suicide attempt is a previous suicide attempt. Apart from that, a couple of minutes back we said that presence of hopelessness is also an important risk factor for suicide. And then male sex and old age, substance abuse, presence of delusions, hallucinations, a person who is divorced or separated, person who is unemployed, who is having a chronic medical illness, who has a family history of suicide, who has poor social support, and who has history of sexual abuse as a child. All of these are risk factors for suicide. Believe me, all these bullet points have been asked in the exams, in the previous years. So just memorize this chart like anything. Let's talk about the next topic, personality disorders. So personality disorders are characterized by abnormal ways of behavior and abnormal ways of experiencing emotions. So the way these people behave or experience results in dysfunction in their life, and that is why it is considered as a disorder. The onset of personality disorders is in late childhood or early adolescence, and by the time these patients reach their 40s, most of the symptoms subside. That is why we say that maturing of occurs by the time people reach their 40s. Now, personality disorders are considered ego-syntonic. If you remember, in OCD, we said that OCD is ego-dystonic, not agreeable to self, whereas personality disorders are ego-syntonic, agreeable to self. Which means, say if I have abnormal ways of experiencing emotions, I'm extremely sensitive, I get hurt too easily. And if somebody tells me that, I would say, no, this is fine. The way I am fine. I don't see anything abnormal in me. This is ego-syntonic. Whatever I'm feeling or the way I am, that is agreeable to me. Whereas a person who is having obsessions, those obsessions are not agreeable to him. He says this is something abnormal. So personality disorders are agreeable to self. People are comfortable with the way they are, and that is why they usually resist treatment, because they don't see anything abnormal in them. They are also not keen in taking treatment for the same. Now, personality disorders in DSM have been divided into 3 clusters: cluster A, cluster B, and cluster C. So let's talk about the cluster A first. The first cluster A PD is called as paranoid PD. Just remember that the term paranoid is kind of equivalent to being very suspicious. So these patients are very suspicious. They are suspicious of others. They are suspicious about the intentions of others, and at times they believe in conspiracy theories. They think that everybody is plotting against them. The second cluster A PD is schizoid PD. Now, schizoid PD patients prefer being alone. They prefer activities that are solitary, where they do not have to deal with another person. They prefer being alone the most. And they are also very cold emotionally. They don't show too many emotions. They don't get attached to others. Because they prefer being alone, they don't show too many emotions. That is why sometimes it is said that schizoid PD can be considered as a part of autism spectrum disorder. The third cluster APD is important as far as your exams are concerned. It is called a schizotypal PD. It is characterized by odd ways of thinking and odd ways of behaving. These patients have odd and eccentric ways of behaving, dressing, thinking, communicating. Everything about them is odd. And they also have what is called as magical thinking. Fantasy stuff such as what will happen if dinosaurs come back, what will happen if machines take over. All these things really excite them. Let's talk about cluster BPD. The first cluster BPD is histrionic PD. These are the people who are very dramatic. They show too many emotions, excessive emotions for no good reason. And the fundamental characteristic of these patients is their extreme desire for attention. They have a very strong need to be the center of attention, and they do anything and everything to get that attention. Then we have got narcissistic PD. Now these patients love themselves. They think they are very talented, they think they are very special, and they give a lot of importance to themselves. And because they love themselves, if anybody criticizes them, they become very angry. And they also demand admiration from others. They think that I'm very good and people should admire me. Antisocial PD, as the name suggests, these patients break laws. They don't follow the rules and regulations. Also, these patients do not have any regard. They do not care for the right of others. They don't care for the emotions of others. Even if they do something wrong, they don't feel guilty about it. Even if they are punished, they don't feel guilty about it. And finally, they are much more prone to the development of substance use disorders than the general population. Perhaps the most important personality disorder as far as your exams are concerned is this one, borderline PD. So these patients usually are very unstable emotionally. They have lots and lots of mood swings. They're very impulsive. They do things without thinking it through. And the most important part is the instability of relationships. They are not able to carry a relationship for too long a duration. Their relationships stay for a very short duration of time, and they go from crisis to crisis. Also, they indulge in self-injurious behavior. In the exams, often you are given the history that the patient has cut the wrist or has taken excessive dosage of medications. These are basically self-injurious behaviors. So the typical question comes like this: a young female comes to the medicine emergency or surgery emergency after cutting the wrist. There has been multiple similar episodes in the past. There is history of multiple relationships in the past. And what is the diagnosis? So this is the prototype question of borderline PD. Also remember that the standard treatment of borderline personality disorder is dialectical behavioral therapy. One of the types of therapy, DBT. Please remember this name. It is often asked in the exams. Let's talk about cluster CPD. The first one is avoidant PD or anxious PD. Now, as the name suggests, these are the patients who are very anxious. They're very sensitive to rejection. They think that others will laugh at me, or others will not like me, or others will criticize me. And because they're afraid of this criticism, they do not socialize. They stay away from social activities to avoid the chances of being ridiculed by others. So they are always anxious and they avoid social activities. Then we have got dependent PD, as the name suggests. These are the patients who are dependent on others for everything, for most of the important things in their life. All the big decisions of their life, which college to go to, which subject to study, whom to marry, how many children to have, they let somebody else take these decisions for them. And they do so because they think that they would not be able to take care of their lives. When they are left alone, they feel very helpless. They feel that I would not be able to handle myself. And lastly, we have got obsessive compulsive PD or anancastic PD, the last cluster CPD. So these are the patients who are always talking about rules and regulations. They're preoccupied with rules and regulations, and they have a perfectionism, but a bad kind of perfectionism, because they are never happy with the stuff they do. So they keep on spending excessive amount of time on the same task. They're very stubborn people. They don't listen to anybody. They want everybody to follow them, but they themselves are not ready to change themselves. Very uptight people, very formal people. They don't enjoy any leisure activities. They don't even laugh. They say that laughing is a wastage of time. And the important thing is, the name is obsessive compulsive PD, but there are no obsessions or compulsions. Obsessions and compulsions are features of OCD, not OCPD. Now, these are the three clusters of personality disorders. Apart from these, this clinical classification, sometimes the personalities have been classified into type A and type B personality. So type A personality people are those who are very competitive. They want to win. They don't play just for the sake of playing. They want to win. And they are always in shortage of time. They want to achieve so much that they're always short on time, called as time urgency. At times they are hostile in an attempt to win, and in an attempt to do better than others. In an attempt to do better than others, they may be hostile to others, and they may get angry very easily. This trait of hostility and anger has been associated with increased chances of development of coronary artery diseases. So type A personality is more likely to develop CAD. In comparison, type B people are chill people. They relax, they enjoy. They say game is for enjoyment, not for winning. A newer one, a type D personality, has been described. It is characterized by negative affectivity, which means these people are more prone to experience negative emotions, and social inhibition, which means they are not able to express themselves. So they experience negative emotions, but they are not able to express themselves, and they are also more likely to develop coronary artery diseases. So both type A and type D are prone to development of CAD. All right, let's talk about the next chapter, which is anxiety disorder. So first of all, as we recently discussed, that as a group, the most common psychiatric disorders are the anxiety disorders. But if they ask you an individual disorder, then you will answer it as specific phobia. As a group, anxiety disorders are more common than any other group of disorders. But if we are asked about a particular illness, particular disorder, the answer is specific phobia. The first one that we want to talk about is panic disorder. Now, what is a panic attack first? Panic attack is an acute attack of intense anxiety with a feeling of impending doom. Give a lot of attention to this phrase, feeling of impending doom. Whenever they give you a question on panic attack, more often than not, they add this phrase that the patient reports a feeling of impending doom. So basically what is happening in a panic attack? Patient is having such a severe anxiety. Patient is having so severe anxiety that he feels that he is either about to have a heart attack, or he is about to go crazy, or he will lose control. So basically, feeling of impending doom means the doom is near, the end is near. The end can be by a heart attack or by going crazy or by some other manner, but the central feeling is that something bad is about to happen. If somebody is having repetitive panic attacks and unexpected panic attacks, then we call it panic disorder. Now, one of the most important question is about the differential diagnosis of panic disorder. So if a patient is coming to you in a panic attack, what would be the presentation? He will be having palpitations, maybe pain in chest, difficulty breathing or heavy breathing, they may be sweating. If somebody comes to you with all these symptoms, what would be your first differential diagnosis? Obviously, it would be myocardial infarction. MI. Or it could also be angina. It could also be arrhythmias. It could also be mitral valve prolapse. What about the endocrine system? Hyperthyroidism, some tumor, pheochromocytoma, carcinoid syndromes, even acute asthma, respiratory disorders like acute asthma or COPD. Somebody who has anemia. Anemia is a hyperdynamic state, may present with palpitations and all. So all these are the differential diagnosis of panic disorder, and these are very important. So if you look at the last point, anemia is also there, hypoglycemia is there, even something like temporal lobe epilepsy. Temporal lobe epilepsy may present with any of the psychological symptoms. Patient may present with severe state of anxiety. It may look like a panic attack, but it may actually be it may actually be temporal lobe epilepsy. So remember this table, all of these are differentials. The typical question goes like, all of the following can be differential diagnosis of panic disorder except, and they will add something that is not from this table. In fact, recently last year they gave a question, which of the following is not a differential diagnosis of panic attack? First option was hypoglycemia, then there was hyperthyroidism, then there was temporal lobe epilepsy, and then there was generalized tonic-clonic seizures. So GTCS is not really a DD for panic disorder, because there would be tonic and clonic movements which are of course not seen in a patient with panic attack. How do you treat a panic attack? So immediately you give benzodiazepines to terminate the attack. Short-term treatment is benzodiazepines, and then you start the patient usually on a SSRI to prevent further panic attacks. And you always add a therapy which is usually cognitive behavioral therapy. Alright, so this was about the panic disorder. What is agoraphobia? So agoraphobia, the definition is fear of places from where escape is difficult. Any such place from where patient feels that it would be difficult to run away from. Any such place in which patient feels that it would be difficult to run away from is a place the patient is afraid to go to. So what are such places? The patient may be afraid of big open spaces. The patient may be afraid of closed places. The patient may be afraid of crowded places. The patient may be afraid of traveling alone. And the patient may be afraid of public transport. So all these places from which it is not easy to escape, the patient is afraid of these places. Now please remember, the diagnosis of agoraphobia is usually comorbid with the diagnosis of panic disorder. Patients who have agoraphobia also usually have panic disorder. How would you treat agoraphobia? Again, for most of the anxiety disorders, the treatment is quite similar. In the short term, we usually use benzodiazepines. We cannot use it for the longer term because benzodiazepines have dependence potential. So shorter term usually benzodiazepines, longer term usually SSRIs, and we always add a therapy. For phobias, the therapy is usually behavioral therapy. For other anxiety disorders, the preferred therapy is usually cognitive behavioral therapy. So for example, for panic disorder, the preferable therapy was CBT, but for agoraphobia, the preferable therapy would be BT or behavioral therapy. Last year, the NEET exam had asked this question on nyctophobia. What is nyctophobia? Fear of dark is called as nyctophobia. Alright, let's talk about the most important anxiety disorder. Before that, we talked about this. The treatment of agoraphobia is, and in fact nyctophobia is, short-term benzodiazepines, long-term SSRIs, and behavioral therapy. Alright, let's talk about one of the very important topics, generalized anxiety disorders. Now what happens is, in phobias, the fear is of a particular situation or a particular condition, which means the anxiety is localized. It is restricted to particular situations. If there's a patient who is always anxious, what is also called as free-floating anxiety, that anxiety is floating freely. This person is always anxious, and this person always worries about every small and trivial thing, then we say that he has generalized anxiety disorder. So two things, free-floating anxiety and the excessive worriness, tendency to worry excessively. Both of these are the central tenets of the generalized anxiety disorder. Now, if somebody is having anxiety all the time, there would of course be the presence of physical symptoms or somatic symptoms of anxiety like sweating, palpitation, there may be increased muscle tension, there may be headache, patient may be irritable. All these things are also symptoms of GAD. What would be the treatment? Short term, benzodiazepine, long term, SSRI, and therapy would be, it's not a phobia, hence we would use cognitive behavioral therapy. Let's talk about the most important anxiety disorder as far as your exams are concerned. It is OCD, or obsessive compulsive disorder. So we know that OCD is primarily characterized by obsessions and compulsions. Now let's spend some time understanding the definition of obsessions or the criteria of obsessions. They are frequently tested in the exams. So obsessions are, now the first bullet point says recurrent and intrusive thoughts, images, or impulses which cause anxiety. So what happens is, say I'm the patient, I will have a particular thought which will come again and again in my mind and it will make me anxious. Say the thought is that my hands are unclean or my hands are dirty. Now this thought comes again and again in my mind, and it's an intrusive thought. Whether I'm teaching, whether I'm eating, whether I'm playing, this thought will come into the mind, my hands are dirty. Second criteria, patient considers this thought as a product of their own mind. Now when this thought comes into my mind, I know this is my thought. I understand this is my thought. Why is this important? Say a patient comes to you and he says, doctor, I keep on getting thoughts that my hands are dirty, and my neighbor is using some kind of technology to put that thought in my mind. In that case, it would not be an obsession, it would become thought insertion. A patient with thought insertion says, somebody is putting a thought in my mind. A patient with obsession says, doctor, I get this thought that my hands are dirty and it's my thought only. I know it's my thought. Third criteria, patient considers these thoughts as excessive, irrational, and senseless. So when this thought comes in my mind that my hands are dirty, I realize that this thought is not true. In fact, I get irritated by this thought because I know that this is a stupid thought, it's a senseless thought. But this thought still keeps on coming in my mind. Now this third criteria differentiates obsessions from delusions. Say somebody had a delusion that his hands are dirty. Now this person who has a delusion that his hands are dirty would insist that his hands are dirty. No matter how many reasons you give him that your hands are not dirty, he would not accept that. He would say, no, my hands are dirty. Whereas a patient with obsessions would say, I know that my hands are not dirty, but this thought keeps on coming in my mind. And lastly, the obsessions, the patient tries to resist these thoughts. I would try to stop this thought that my hands are dirty, and I would try to neutralize it. And how would I neutralize it? By indulging into some behaviors that are called as compulsions. So compulsions are repetitive behaviors or mental acts that are performed in the response to obsessions, and they may decrease the anxiety for some time. So for example, I would go when I'm getting this thought that my hands are dirty, finally I may give up, I'll go and I'll wash my hands. Now this washing of hands is a compulsion. I did this to decrease the anxiety. The anxiety goes down for some time, but after some time the entire cycle repeats itself. So please remember, both obsessions and compulsions are ego dystonic. What is the meaning of ego dystonic? Ego dystonic means not agreeable to self. Something which you do not agree with is ego dystonic. So when I had obsessions that my hands are dirty, I did not like it. I did not agree with it. And when I had to resort to hand washing, I did not like that either. So both these things were dystonic. I did not like it. That's why we call it ego dystonic or ego alien. What causes OCD? Serotonergic dysregulation is responsible for development of OCD. And you perhaps remember that deficiency of serotonin has also been implicated for the development of depression. So it's but natural that OCD and depression are often seen together. They are often comorbid conditions. Now, while the neuroimaging findings are not always consistent, but it has been found, especially in children, that those who have OCD, the MRI of these children or those patients show bilateral decrease in the volume of caudate. This has been a question of JIPMER, in last 2 years. And finally, let's talk about the types of OCD. Now, there are two types of OCD which are the most common. The most common type of OCD is obsessions of contamination followed by compulsions of washing, the example that we just took. And the second most common type of OCD is pathological doubts followed by compulsions of checking. So what happens in the second type is patient will have repetitive doubts. For example, you lock the door, you lock it, you come downstairs, you start your car, and the doubt comes, did I lock the door properly? This is a doubt. Now, despite remembering clearly that you locked it properly, you are not able to convince yourself. The thought keeps on coming, did I lock it properly? Did I lock properly? And finally, you have to go back and you have to check it, which is the compulsion of checking. So, these are the first two types and the two most common types of OCD. Let's talk about the treatment of OCD. Now, first thing first, a combination of medications, pharmacotherapy and psychotherapy is the most effective treatment. AIMS question from the past year, a combination is what gives you the best results. When we talk about pharmacotherapy particularly, or we talk about pharmacotherapy only, we can say that the first line treatment of OCD pharmacotherapeutically is use of SSRIs or clomipramine. Now, clomipramine is a TCA, tricyclic antidepressant. If somebody asks you to pick between these, would you pick SSRI or would you pick clomipramine? You would pick SSRI. Why? Because of better side effect profile. So both of them are first line treatment, but we usually go with SSRIs first because of their better side effect profile. Sometimes in patients who do not completely respond to them, we can use antipsychotics as adjuvants. We can use an antipsychotic to increase the effect of primary drug here. They are used as adjuvants, antipsychotics. They do not have any role by themselves. If you give a patient with OCD only antipsychotic, it would not show, he would not show any improvement. But antipsychotics, when added with SSRI or a TCA like clomipramine, may increase their efficacy. Apart from the pharmacotherapy, let's talk about the psychotherapy. Now, this is actually more important as far as our exams are concerned. Exposure and response prevention is the psychotherapy of choice in patients with OCD. So if you look at it, there are two terms here, exposure and response prevention. So what happens is, say I had that OCD where I felt that my hands are dirty. What would you do in the therapy is, you would make me touch something. Say you ask me to touch the table. Now when I touch the table, this is the exposure. Why? After touching the table, the frequency of the thought that my hands are unclean, it goes even further up. So this is the exposure part. And now you tell me not to resort to compulsion. You tell me not to wash hands for as long as possible. So I touch the table, thoughts increase, but I do not wash hands. Not washing the hands is the response prevention part. So exposure and response prevention is considered to be the most effective therapy in OCD. Most of the books consider ERP or exposure and response prevention as a type of cognitive behavioral therapy. Some books consider it as a type of behavioral therapy. The American Psychiatric Association guidelines consider it as a type of CBT or cognitive behavioral therapy. Let's talk about the next topic, the trauma and the stress related disorders. So we start of course with PTSD, post-traumatic stress disorder. Now please remember, PTSD is something that follows a very severe trauma, a significant trauma. The trauma is so severe or significant that it can overwhelm anybody or everybody. And it's a trauma that could have caused or that did cause a serious threat of injury to either self or others. So traumas like getting caught in a war, getting caught in a natural calamity like flooding, earthquakes, rape, some serious vehicle accident, all these things that can overwhelm anybody can cause PTSD. Now there are three main features of PTSD. Say I was driving a car and I got hit by a truck and I barely survived. and now I develop PTSD. What would be the three features? The first and the foremost feature would be the intrusion symptoms. Say this accident happened 6 months back. Now I have developed PTSD. While recording this lecture, suddenly I may feel that I am again driving the car and I am about to be hit by a truck. That image of truck hitting me flashes in front of my eyes. This is called as a flashback. I may actually relive that time. I may actually feel as if it is happening all over again. So flashbacks, the most important symptom. Apart from flashbacks, I may have repetitive thoughts about that trauma or recurrent dreams about that trauma. Second symptom would be avoidance. So anything and everything that reminds me of that trauma is avoided by me. Say I had an accident in South Delhi, so I stopped going to the South Delhi because going to South Delhi reminds me of the trauma. Maybe I stopped driving the car because sitting in that car in the driver's seat reminds me of the trauma. Maybe I stopped talking to that friend who was sitting with me because looking at his face reminds me of that trauma. So I avoid anything and everything that reminds me of that trauma. And third, there would be hyperarousal symptoms. The arousal symptoms like hypervigilance. Hypervigilance is an increased state of vigilance. I keep on looking for any potential threatening stimuli. And there is exaggerated startle response. What is startle response? If somebody suddenly takes your name in a class, you may get a bit surprised. But if you have exaggerated startle response and somebody takes your name in the class, you would get so surprised that you would just jump out of your chair and you will fall down on the ground. The response is so increased. These are all indicative of increased level of anxiety. To make a diagnosis of PTSD, the symptoms should continue for at least 1 month. If the symptoms have been continuing or the duration of symptoms is less than 1 month, then we make a diagnosis of ASD, acute stress disorder. But there's an important point here. Usually the symptoms of PTSD start immediately after the trauma, but there are cases when the onset of the illness may be delayed by more than 6 months. Somebody had a trauma today, for next six months no symptom, and then he develops PTSD after 6 months. This is called as PTSD with delayed onset. And for some reasons, this is the favorite question of PGI examiners. They keep on asking about PTSD with delayed onset. What is the treatment of PTSD? The treatment of choice is cognitive behavioral therapy. CBT or cognitive behavioral therapy is the therapy of choice for almost all the psychiatric disorders nowadays, except for, of course, phobias and certain other disorders. But if you find a question in the exam where they're asking you about a particular therapy and you don't know the answer, your best bet is CBT. So CBT is the treatment of choice. If they ask you about the drug of choice, then it would be SSRIs. A newer treatment modality has come up, which is called as EMDR, eye movement, desensitization and reprocessing. Just remember its name. It's the newer kid on the block, and it is yet not the treatment of choice. All right, let's talk quickly about the somatoform and dissociative disorders. Now, first of all, somatoform disorders. If you look at DSM-5, the newer name for these disorders is somatic symptom and related disorders. Basically, these are the disorders which present with a physical symptom, physical complaint that is considered to be originating from a psychological cause or psychogenic cause. So there are 3 important somatoform disorders that we must be aware of. The first one is called as somatization disorder. The newer name for somatization disorder in DSM-5 is somatic symptom disorder. Basically, what happens in somatization disorder is the patient is preoccupied with a physical symptom or a group of physical symptom. The patient may come to you and may again and again complain that I'm having pain in the abdomen, I'm having headache, so pain symptoms, GI symptoms, that bloating is there, diarrhea is there, constipation is there, there may be neurological symptoms, that tingling is there, paresthesias are there may be sexual symptom like dryness of vagina, loss of libido. So a lot of physical symptoms are there, and there is no physical cause that can be found for those symptoms. So preoccupation with symptoms is somatization disorder or somatic symptom disorder. Another type of patients come to you who are not preoccupied with the symptoms, they are preoccupied with the diagnosis. They are preoccupied with the belief that they have a severe illness or a serious medical condition. A patient may come to you and he may say that, doctor, I have stomach cancer. And you ask him, how do you know it? He will say, after eating the meal, some kind of sound comes out of my bowel. That is a clear-cut indication of stomach cancer. You get all the investigations done, everything comes out to be normal, you reassure the patient listens to you, but then he goes to another doctor and says, doctor, I have stomach cancer. So this patient is preoccupied with the diagnosis, and this is called as hypochondriasis. So preoccupation with symptoms versus preoccupation with the diagnosis. The newer name for hypochondriasis is illness anxiety disorder. And there are a third group of patients who are preoccupied with their physical appearance. The diagnosis is body dysmorphic disorder. Patient comes to you, she says, my nose is too long, my ears are too big, my lips are too thin. When you examine, everything is fine. This is body dysmorphic disorder. Alright, let's talk about the dissociative disorders. Now, dissociative disorder is an interesting topic, but a low-yield topic. Not many questions come from it. So, what is dissociation? Basically, there are many mental functions that usually are in sync with each other. For example, your memory, your consciousness, your perception, your motor behavior, everything is in sync with each other. But in dissociative disorders, one of these mental functions get detached or dissociated from rest of the mental functions. This is what is dissociation is. And the dissociative disorders are unconscious, which means the symptoms that get produced, patient do not produce them deliberately. It's not that patient is doing it willfully, the symptoms are getting produced unconsciously. Now, there are many forms of or many types of dissociative disorder. The most common type, as far as your exams are concerned, almost 95% of the times, the question comes from a particular type, which is conversion disorder. There are many types of dissociative disorder, but we will focus on conversion disorder. So what happens in conversion disorder is, the patient presents with symptoms that are suggestive of a neurological deficit. But when you do the investigations, there is no neurological cause that can be found. What does it mean? Patient may present with the motor symptom, say patient presents with paralysis. Patient may present with a sensory symptom, say loss of vision, or patient may present with seizures. All of these are neurological symptoms, but when you do the investigations, everything comes out to be normal. Say patient is having seizures, and at the time of seizures, if you do the EEG shows normal recordings. So that is why it is called as a pseudo seizure. Now what happens is, the symptoms that these patients present with in conversion disorder, they do not really match up with any known neurological lesions. For example, say the patient comes to you and he says that I am not able to have any sensation in my left hand. And when you do the mapping of sensations, you find that transversely, the upper part, the upper half does not have sensation and the lower half has sensations. Now this distribution does not correspond to any nerve. This distribution does not correspond to any known nerve lesion, and that gives you an indication that perhaps it's not a neurological disorder, perhaps it's a psychological cause. So the symptoms do not match with any anatomical or physiological principle. They do not conform to any anatomical or physiological principle. Another important feature is what is called as labile indifference. These patients, when they develop symptoms, it appears as if they are not concerned with the symptoms. Say somebody develops a sudden vision loss, you expect them to be in a state of panic. But a patient with conversion disorder, after developing, say, vision loss in the right eye, may come to you and he may say, well, doc, I am not able to see with my right eye, but it's okay, it happens, my left eye is still working. As if they're very casual about it. This is known as labile indifference. Labile indifference is a sense of indifference towards the symptoms. And lastly, one of the important differential diagnoses of conversion disorder is AIP, acute intermittent porphyria. Porphyria may also present with such baffling symptoms, but usually in patients with AIP, the history of abdominal pain is given in the exams, and that helps you in differentiating the two. Apart from the lab investigations, of course, on history basis, this is an important indicator. Apart from conversion disorders, another important disorder is what is called as DPDR, depersonalization, derealization disorder, a type of dissociative disorder. Now, depersonalization is a feeling of unreality of self. Patient feels as if he is unreal. Sometimes patient come to you and say that I feel unreal. I feel as if I have come out of my body and as if I am observing myself, as if I am seeing myself like it happens in a movie. Now remember that the patient is only feeling like that. Now while the person is having this feeling of unreality, at the same time he realizes, he understands that this is just his feeling. He does not lose the contact with reality. So, for example, I feel that everything is unreal, I feel unreal, I feel as if I'm seeing myself, but at the same time, I know it's just my feeling, it is not really happening. I'm not really out of my body, I'm not really looking at myself. I realize that this is just my feeling, not the truth, not the fact. So, that is the meaning of the bullet, that reality testing is intact. I'm telling you this because this is this year exam question. And then we have derealization. So depersonalization is feeling of unreality of self. Derealization is feeling of the unreality of the world. When the world looks unreal, environment looks unreal, that is derealization. Now, again, dissociative symptoms or symptoms of dissociative disorders were unconscious. Patients were not deliberately creating them. When we talk about the factitious disorder or Munchausen syndrome, we say that the patient is deliberately producing the symptoms just to get medical attention. Patient is making stories, making false symptoms, and why so? Because he wants to get medical attention. Patient may come to you in the emergency, may make a story that I am having pain in the abdomen, it started near the umbilicus, going towards my right iliac fossa, and you as a young doctor think that, well, this is a classical presentation of appendicitis, let's admit him, and that is what patient wanted. He wanted medical attention. The patient, after getting admitted, wants that everybody should behave with him as if he is really sick. He wants to take the sick role. So, what is sick role? The desire by the patient that everybody behaves with them as if they are very sick. It is classically seen in patients with factitious disorder. But remember that a patient with factitious disorder deliberately creates the symptoms. But why does he do so? Because he wants medical attention. The reason for development of symptoms is medical attention. He wants attention. If somebody develops false symptoms or somebody fakes symptoms to get money, say somebody wants to get money from the insurance, or somebody was sentenced to prison but they don't want to go to prison and that's why they are faking symptoms, or somebody was posted in a difficult terrain, they don't want to go to that terrain and that's why they are faking symptoms. Now these would be called as people who are having malingering, who are doing malingering. Malingering is not a psychiatric disorder. Here false symptoms are created with a conscious and external incentive such as financial incentive or avoiding a legal case. So malingering, the reason is an external incentive. Factitious, the reason is what the person wants is attention. So sometimes they give you history that somebody has been sent by a court and you're examining him, his history and examination findings do not match. Well, there is the diagnosis of malingering. Alright, so this was about the important neurotic disorders, and now let's talk about the substance related disorders. Alright, let's talk about the next chapter, which is substance related disorders. So first of all, let's talk about dependence. When do we say that a person has become dependent on a particular substance? Now there are certain features of dependence. What are they? The first feature is tolerance. What is tolerance? The increasing amount of substance is required to get the desired effect. So for example, somebody who would earlier get intoxicated with say 30 ml of alcohol or 60 ml of alcohol, now he requires 120 or 150 ml of alcohol to get intoxication. So the amount required has gotten up or it has increased. The second feature is the development of withdrawal symptoms. If the patient starts developing withdrawal symptoms, which are the characteristic symptoms that develop when the person stops intake of a particular substance, that is also suggestive of development of dependence. Now, one thing important is presence of tolerance and withdrawal symptoms is indicative of physical dependence, which means the patient's body has become dependent on that substance. Now, there is a question that is asked repeatedly: hallucinogens, which are a group of drugs that include LSD, phencyclidine, ketamine. All these hallucinogens, they do not result in development of, or they are not associated with development of physical dependence. So if a person is using hallucinogen like LSD, there cannot be development of tolerance to LSD, and there are no withdrawal symptoms associated with LSD. So remember that hallucinogens are not associated with physical dependence. Apart from the signs of physical dependence, craving, an intense urge to take a substance, and inability to control substance taking behavior are some other features. So what is the meaning of the fourth point? So people, when they start using any substance, say somebody starts using alcohol, in the beginning they have certain control over the alcohol taking habit. For example, they would have some rules that I would drink only on a Saturday night. I would not go beyond 2 packs of alcohol. Once the dependence start to develop, all the rules, they start getting broken. People drink till the last drop of alcohol is left in the bottle. And then there is progressive neglect of alternative ways of pleasure. The only thing that makes these people happy once the dependence develop would be consumption of the particular substance, and continued use of the substance despite negative consequences. A person knows that alcohol is resulting in development of alcoholic liver disease, but despite that knowledge, he continues to use the substance, alcohol in this case. So these are some features of dependence. The first and second are the important ones. Let's talk about the individual substances, starting with the alcohol. Now, a couple of things about the alcohol intoxication. When we drink alcohol, the BAC, blood alcohol concentration, increases. In India, if you are driving with your BAC more than 30 milligram per deciliter, that would be considered as illegal. So the legal limit of driving under alcohol influence is 30 milligram per deciliter of BAC. Also, another important feature of intoxication of alcohol, intoxication with alcohol, is what is called as alcoholic blackout. What is alcoholic blackout? When the BAC is between 200 to 300 milligram per deciliter, the person who is intoxicated with alcohol may have difficulty in making memories, which presents as alcoholic blackout. So what happens is, whatever the person is doing when the BAC is between 200 to 300 milligram per deciliter, he may not be able to recall it the next day. Whatever he did, he may not be able to recall it the next day. So it is a form of anterograde amnesia. Anterograde means something which happens after the event. So since the amnesia is happening after consumption of alcohol, it is anterograde amnesia. Now the interesting thing is, say between 200 to 300 milligram per deciliter, the person was talking with his friends, say about a business plan, and the next day he is not able to recall that any such discussion happened. But while he was discussing the business plan with the friends, at that time he appeared to be in his senses. He did not appear to be in a state of confusion to the onlookers. But the next day he does not remember anything. Right? So remember, while doing those activities, he appears to be in control. He appears to be in his senses, not confused. But the next day he is not able to recall any of the things that he did. So this is the BAC that corresponds to alcoholic blackouts. Now the important question that comes from alcohol is on the withdrawal symptoms. The alcohol withdrawal symptoms start after 6 to 8 hours of the last drink, and the most common alcohol withdrawal symptom is tremors. Apart from that, some other sympathetic symptoms like anxiety, hypertension, mydriasis, restlessness, then there can be nausea, vomiting, all these can be seen. After 12 to 24 hours, the patient may develop alcoholic hallucinosis. What is alcoholic hallucinosis? Patient may start developing hallucinations. He may start experiencing hallucinations without any disturbance of consciousness. The patient is alert and awake in his senses, but starts hearing some voices. The hallucinations are coming without any disturbance of consciousness. After 24 to 48 hours, patient may develop seizures, alcohol withdrawal seizures, which are usually GTCS in nature. And what happens is, multiple seizures come one after another. The patient has first seizure, 5 minutes later he has a second seizure, 10 minutes later he has a third seizure. So since the seizures are coming in clusters, we at times call them as cluster seizures. And after 48 to 72 hours, the most dreaded complication of alcohol withdrawal, delirium tremens. Why dreaded? Because of high rates of fatality. Now, in delirium tremens, we will talk about delirium later on. In delirium tremens also, one of the characteristic feature is hallucinations, usually visual hallucinations. But in delirium tremens, the visual hallucinations that occur, they are associated with disturbances of consciousness. Patient is confused, the consciousness is altered or clouded, and along with that, patient is having hallucinations. In comparison to this, a patient who is in alcoholic hallucinosis has hallucinations but without any disturbance of consciousness. Now, we need to know when can we call the alcohol drinking as problematic alcohol drinking. So there are certain questionnaires. The most famous one is CAGE questionnaire. You ask the patient 4 questions, CAGE. The first question is, have you ever felt the need to cut down on your alcohol intake? Second question, have you ever felt annoyed when people talk about your alcohol consumption habits? Do you feel guilty about your alcohol taking habit? And do you need alcohol as the first thing in the morning to even steady your nerves? If the patient says yes to 2 or more than 2 of these questions, then we say that the patient is screening positive and possibly he has problematic alcohol drinking. Apart from CAGE questionnaire, there are certain other tests such as audit. It is a commonly used test. The full form goes like alcohol use disorder identification test. Even this test can tell us about the presence of problematic alcohol drinking. But both of these tests are screening tests. If you want to know the severity of alcohol dependence, then we use SADQ or severity of alcohol disorder questionnaire. Now, if somebody has been consuming alcohol for too long a time, it results in a lot of complications. We will be limited to the neuropsychiatric complications. So we all know that alcohol can cause Wernicke-Korsakoff syndrome. The neurocognitive disorder caused by alcohol, long-term alcohol consumption is Wernicke-Korsakoff syndrome. Now it is pretty important. A lot of questions are asked from this topic. There are 2 components of Wernicke-Korsakoff syndrome. The first component is Wernicke's encephalopathy, which is the acute complication. And what is the cause of it? Obviously, thiamine deficiency. So, caused by thiamine deficiency, what is the triad? What are the classical symptoms of Wernicke's encephalopathy? We all know the mnemonic goes like GOA, G-O-A. So, G stands for global confusion. O stands for ophthalmoplegia. Ophthalmoplegia is paralysis of extraocular muscle. Now remember, ophthalmoplegia is most commonly caused by 6th nerve palsy followed by 3rd nerve palsy. The most commonly involved is 6th nerve, and hence the most commonly involved muscle is lateral rectus. And A stands for ataxia. Now, when a person comes to you in Wernicke's encephalopathy, you are supposed to give him high dosage of parenteral thiamine, intramuscularly or intravenously. And when you give thiamine, the first symptom to improve is ophthalmoplegia, followed by confusion, and lastly the ataxia improves. An important thing, in a large number of patients, ataxia does not improve completely. There can be residual symptoms. So there can be residual ataxia. This has been asked in the exams. The chronic complication is called as Korsakoff syndrome or Korsakoff psychosis, again caused by thiamine deficiency. The most important symptom is amnesia. What kind of amnesia? Both anterograde as well as retrograde. So again, let us understand these 2 terms. Say I'm standing here and something falls on my head and I develop amnesia. I would have 2 kinds of memory disturbances. I will forget things that happened in the past, which is retrograde amnesia. And I will not be able to remember things in the future. This is, I will not be able to make memories from now on. This is anterograde amnesia. So in Korsakoff, both of these are present, but anterograde amnesia is more prominent than retrograde amnesia. Now, an important thing is, if anterograde amnesia is present, if you are not able to make new memories, it is impossible to learn new stuff. For example, while I'm speaking, you are learning something by making new memories. If you cannot make a memory, you cannot learn. So in patients who have anterograde amnesia, learning is automatically impacted. Apart from amnesia, the second symptom is confabulations. So what are confabulations? False stories made to fill memory gaps. Say a person goes back home, his wife asks him, where were you in the morning? He does not remember. So he makes a false story and tells that I went to that relative and together we went somewhere. Now he's creating a false story to fill that memory gap. This is called as confabulation. Alright, how do you treat Korsakoff syndrome? Again, of course, by giving thiamine. We give oral thiamine for long period of time. Now, a large number of brain structures are involved in the development of Wernicke's encephalopathy and Korsakoff syndrome. But if you're asked to pick one particular area of brain, then you will say mammillary bodies. Mammillary bodies are most impacted in the development of Wernicke's and Korsakoff. And we have talked about the treatment. For Wernicke's, high dose of parenteral thiamine, and for Korsakoff, long-term oral thiamine. Alright, let's talk about the treatment of alcohol dependence syndrome. If somebody has developed alcohol dependence, how do we treat him? Now, treatment of any substance follows two stages. The first stage is always detoxification. In detoxification, what we do is we primarily take care of the withdrawal symptoms. The patient has stopped consuming alcohol. Now he's having withdrawal symptom. You manage it. This is the first stage or stage of detoxification. The drug of choice for alcohol detoxification is obviously benzodiazepines. Once the detoxification is over, now comes the main part. The patient has stopped taking alcohol. The withdrawal symptoms have been taken care of. Now we have to ensure that the patient does not go back to drinking alcohol again. So we have to do something to prevent the relapse. So this is called as the stage of relapse prevention or maintenance of abstinence. Now we can take two approaches. The first approach is we can give the patient some kind of medication on the top of which, if he consumes alcohol, he will have a very unpleasant reaction, and so he would become afraid of consumption of alcohol. So you are trying to deter the patient from consuming alcohol. This is called as the approach of using deterrent agents or aversive agents such as disulfiram. But this approach does not work that well. The better approach is to decrease the craving for alcohol. So we use anti-craving agents such as naltrexone, acamprosate and topiramate. If you're asked to pick one of these, you will go with naltrexone. Apart from the medical methods, we also encourage patients to go and join a group called as Alcoholic Anonymous. Now, Alcoholic Anonymous is a group in which patients who are at different levels of quitting alcohol or who are at different stages of their abstinence, they come together and they help each other out. So it's a self-help group. The doctor is not involved. It's a self-help group. And it is called as 12-step self-help group because a person is supposed to follow or go through 12 different steps before he is completely free of the alcohol. Now, important thing is, in this self-help group, you do not get any kind of incentive to leave alcohol. This was a question that was asked by the NEET exam, so I'm just mentioning it. There is no kind of incentives involved in quitting the alcohol. It's not that you'll be given some money if you quit the alcohol. Alright, let's talk about opioids. A couple of things. Most commonly abused opioid is heroin. And the street name of heroin is smack, or sometimes it's called as brown sugar. Some other opioids include morphine, codeine. Is the overdosage of opioid lethal? Can it be lethal? The answer is yes. Once AIMS asks this question, what is the mechanism of action of death in persons who have taken overdoses of opioids? The answer is obviously respiratory depression. And what is the drug of choice for opioid overdosage? Of course, intravenous naloxone. Now, the most important topic in this entire chapter is on the withdrawal symptoms of opioids. Large number of questions have been asked from this topic, so it's a very important one. What are the withdrawal symptoms of opioids? So remember, opioid withdrawal presents with a flu-like syndrome. It appears as if patient has developed flu. There is watering from everywhere. There is lacrimation, there is rhinorrhea, there is sweating, there is diarrhea. And then there are two characteristic opioid withdrawal symptoms. What are they? We have got yawning and we have got piloerection, goosebumps. Apart from this, mydriasis, of course, opioid intoxication or opioid poisoning is typically associated with meiosis, and opioid withdrawal is associated with mydriasis. There is severe body ache and insomnia. Now, all these withdrawal symptoms, they have been tested in the exams. They have asked questions from all these withdrawal symptoms. How do we treat opioids? The first step, as we know, would be detoxification. We have to take care of withdrawal symptoms. Interestingly, the drugs used in opioid withdrawal are opioids themselves. We use long-acting opioids like methadone, buprenorphine, or dextropropoxyphene for management of withdrawal symptoms. Long-acting opioids are used. Another approach is to use alpha-2 agonists like clonidine or lofexidine, but it is not the preferred approach. Once the detoxification is over, we go to the next step, maintenance of abstinence or the relapse prevention, and again we use the long-acting opioids like methadone or buprenorphine. This is called as opioid substitution therapy. Why? You are substituting one opioid like heroin with another opioid like methadone. The advantage is the person is using IV heroin. Apart from the ill effects of heroin itself, he is also susceptible to development of HIV, he might contract hepatitis, he might indulge in antisocial activities to procure these drugs. By using oral methadone given by the government approved centers, we are at least able to decrease the harm that is being caused by the consumption of opioids. And if you're asked to pick one out of all these, you will go with methadone. In a small minority of cases where the patient is highly motivated, rather than using less harmful opioids, we prescribe the patient naltrexone. Naltrexone, which you know is an opioid antagonist. So this technique is less commonly used, is less successful, but more commonly asked in the exams. Please remember, the only role of naltrexone in opioid dependence syndrome is in the maintenance of abstinence or relapse prevention. Apart from this, along the lines of Alcoholic Anonymous, we have got Narcotic Anonymous, in which patients can come together. It's a self-help group. Let's talk about cannabis. Cannabis is the most commonly used illegal drug in India as well as worldwide. That reminds me, what is the most commonly used substance in India? And what is the most commonly abused substance in India? The answer to both these questions is tobacco. The most commonly abused as well as the most commonly used substance in India is tobacco. But if somebody asks you what is the most commonly used substance in the world, the answer is alcohol. Most commonly abused substance in the world, alcohol. Alright, let's talk about cannabis. We all know that cannabis is derived from the plant Cannabis sativa. The active ingredient of cannabis is delta-9 THC. And what are the street names of cannabis? I'm sure all of you know it. Marijuana, weed, grass, pot, all those things, joints. Now from cannabis, they ask very specific questions. The first one is on the flashback phenomena. Now what happens in flashback phenomena is, say today I consume cannabis, I smoke, say, ganja. Whatever I experience today after smoking ganja, I may experience it again 6 months later without even using cannabis, without even smoking ganja. So today I smoke something, I had some experience. 6 months later, I will have a flashback of the same experience even without using cannabis. This is the flashback phenomena. 6 months later, I am having the flashback for today. Then we have got run amok. Now I think you have read about it in your forensic also. What happens is, the patient consumes cannabis, and after consumption of cannabis, he becomes very aggressive and thrashes whosoever comes in front of him. So extreme rage that develops after cannabis intake, in which person may hit others, injure others indiscriminately. Whosoever comes in front of the person, he just thrashes him, he just hits him. Then we have bad trips. Now usually people smoke cannabis to feel pleasure, to feel that euphoria. But sometimes when they smoke cannabis, they may start experiencing hallucinations, they may feel fearful, and it might be a very unpleasant reaction where they are hearing voices, they are feeling paranoid, and they may feel that they are about to go crazy. So this unpleasant experience after using cannabis is called as a bad trip. Now, this is a very important point. PGI people love this question. Earlier, we used to say that cannabis does not cause any physical dependence, which means that there would be no tolerance or withdrawal symptoms. But over the years, it was found that cannabis does cause mild withdrawal symptoms, especially irritability. So remember, cannabis withdrawal symptom, irritability, very frequently asked. Alright, since it does not cause strong withdrawal symptoms, there is no specific agent for cannabis. The treatment is symptomatic only. Let's talk about hallucinogens. So the prototype hallucinogen is LSD, lysergic acid diethylamide. We have some others like mescaline, psilocybin. We have got MDMA. The street name of MDMA is ecstasy. Then we have got phencyclidine. The street name of phencyclidine is angel dust. And then we have got ketamines. Again, a couple of points that must be remembered about hallucinogens. Let's focus on those. Hallucinogens very closely mimic the things that we see in cannabis. For example, hallucinogens also cause flashback phenomena. Hallucinogens also cause bad trips. And both cannabis and hallucinogens are also associated with a particular type of hallucinations. What were they? Reflex hallucinations. If you remember the first chapter, stimulus in one modality produces hallucination in another modality. I said they are seen with cannabis and LSD intoxication. So we have got bad trips, we have got flashback phenomena, and we talked about this thing that hallucinogens do not cause tolerance or withdrawal symptoms, and hence there is no physical dependence on hallucinogens. Cocaine, derived from which plant? Erythroxylum coca. Now, cocaine, when it was being prepared as a local anesthetic agent. In fact, cocaine does have sodium channel blocking properties, and it has been used used in ENT surgeries also. You can remember this by the fact that the name cocaine sounds pretty familiar. It sounds pretty similar to other LAs like lignocaine, lidocaine, pilocaine, right? So it has got LA, it has got local anesthetic properties, particularly blockade of sodium channels. And cocaine is a very strong vasoconstrictor. How does cocaine work? Its mechanism of action is blockade of reuptake of dopamine and norepinephrine receptors. It blocks the reuptake of dopamine and norepinephrine by blocking the receptors. Now, if the norepinephrine reuptake is blocked, will it result in vasoconstriction or vasodilatation? Obviously, vasoconstriction. So, when people take cocaine, it can result in increased blood pressure because of vasoconstriction, and if the vasoconstriction is of the coronaries, it can even cause myocardial infarction. Now, we know that cocaine is usually snorted. There is powder that you take using usually a paper roll. You take the powder directly into the nasal cavity and it is absorbed through the nasal mucosa. Now, cocaine is a vasoconstrictor. If it again and again causes the constriction of the vessels of nasal mucosa, later on it may cause the nasal septal perforation. Also remember, cocaine is associated with development of seizures, and smoking cocaine can cause jet black pigmentation of tongue. This jet black pigmentation of tongue is a pet question of examiners. Just remember that cocaine is associated with development of jet black pigmentation of tongue. Now, we are also saying that cocaine blocks the reuptake of dopamine. So the dopamine levels will also increase in the synapses, and it may create a situation where there is a hyperdopaminergic state in the brain. And we know that the hyperdopaminergic state is also seen in which condition? Schizophrenia. So sometimes after taking cocaine, after cocaine intoxication, patient may start developing delusions and hallucinations. And the symptoms are quite similar to paranoid schizophrenia. You think that the patient has schizophrenia, but then you get the urine test done and you find cocaine in it. So remember that cocaine intoxication can cause these symptoms. And obviously the famous question that cocaine intoxication can cause tactile hallucinations. The patient may experience that there are small insects crawling under the skin, also known as cocaine bugs, also known as Magnon phenomena, also known as formication. These are all tactile hallucinations after taking cocaine. Alright, tobacco. The active ingredient is, of course, nicotine. We'll stick to the important points. The first question is on the withdrawal symptoms. What are the withdrawal symptoms of tobacco? Those of you whose friends are smokers, they would know that when your friend does not get to smoke, they become very irritable. They say that they are not able to concentrate. Smokers will also tell you that when they are not able to smoke, they feel very restless, they feel very anxious. Other withdrawal symptoms include bradycardia. Now, this bradycardia has been asked multiple times. Remember that nicotine withdrawal, one of the important nicotine withdrawal symptoms is bradycardia. Then there is drowsiness. People feel drowsy, but they are not able to sleep. That's why called as drowsiness, but paradoxical insomnia. There is increased appetite. There can be weight gain and depression. Patient may feel very depressed. People may feel very depressed. Another important withdrawal symptom that is not mentioned here is constipation. People who are chronic smokers often tell you that they are not able to go to the toilet unless they smoke. Constipation is another important withdrawal symptom. Now, in the last 3-4 years, lots of questions from the treatment of tobacco dependence. So all of us know about the nicotine replacement therapy. That is, we can use nicotine gums, we can use nicotine lozenges, we can use nicotine sprays or nicotine patches. Basically, we are trying to give nicotine by an alternative route. But the questions are coming from the drugs that can be used. In fact, this year NEET question, which drug can be used for the cessation of tobacco? And the famous drug is varenicline. The varenicline or varenicline is a comparatively newer drug which has been used for the treatment of nicotine dependence. And we have to memorize the mechanism of action of varenicline. It is a partial agonist at alpha 7 and alpha 4 beta 2 nicotinic acetylcholine receptor. Remember this, and also remember that one of the rare but important side effects of varenicline is suicidal thoughts. The person may develop suicidal thoughts. It happens extremely rarely, but it has been asked in the exams. The other drug that has been used for the treatment of tobacco dependence, the older one, is bupropion. Alright. Now, what are rave drugs? So, rave drugs are those drugs that are used for recreational purposes, the party drugs. People just consume them and then they go to a party and then they dance for 2 days straight, right? So the party drugs or the rave drugs, the examiners usually ask the name of these rave drugs. So we need to remember that the prototype of rave drug is LSD, lysergic acid diethylamide, but some people use amphetamines or gamma hydroxybutyric acid or even ketamine. Another group of drugs, unfortunate group of drugs, are called as date rape drugs. Now, these date rape drugs are basically used to decrease the alertness of the other person, and by decreasing the alertness, people try to sexually abuse the other person. That is why called as date rape. And these include benzodiazepines like flunitrazepam, GHB, gamma hydroxybutyric acid, and the ketamine. Just remember the names. They have been asked in the last 5 years in the exams. So this is about the substance related disorders, high yield topic. Let's talk about some smaller topics now, starting with the eating disorder. We will start with anorexia nervosa. Now, the primary feature of anorexia nervosa is disturbance of body image. What is the meaning of disturbance of body image? Basically, the way a person perceives himself to be or herself to be, the way they perceive their body is called as body image. So what happens is, in anorexia nervosa, say a normally weighted girl looks at herself in the mirror. When she does that, what she sees is, or what she perceives is, a fat girl, not a normally weighted girl. So normally weighted girl looks at herself in the mirror, she perceives a fat girl and she tries to lose weight. Apart from that, there is extreme fear of gaining weight. So these patients, though they are underweight, they are still very afraid that they will become fat. Because of this, the weight loss is loss is there, the food intake is restricted usually, and that results in a BMI which is lesser than 18.5 kilogram per meter square. So this criteria of BMI being less than 18.5 kilogram per meter square has been recently added in the ICD-11. So apart from these three main features, the fourth thing is there are physical signs and symptoms of starvation. When people restrict their food intake, there are a lot of hormonal changes that happen in the body, and they manifest in features such as amenorrhea, especially in those who have significant weight loss. So one thing that must be remembered is earlier in the older classifications, amenorrhea was needed. It was a important diagnostic sign. It was needed to make a diagnosis of anorexia nervosa, but in the recent additions in the ICD-11 and the DSM-5, anorexia nervosa can be diagnosed even without amenorrhea in the females. So though it's a common symptom, it's a very important symptom, but it is no longer required to make a diagnosis. So these are the four features. Now please remember, anorexia nervosa is usually seen in adolescent females, young girls, adolescent females. And one of the interesting aspects of anorexia nervosa is there is no anorexia in anorexia nervosa. Anorexia means lack of appetite. The appetite is normal in patients with anorexia nervosa. Hence, anorexia nervosa is a misnomer, a wrong name, because there is no anorexia in anorexia nervosa. Another important aspect is that these patients with anorexia nervosa often have disturbances of sexual development. Either the sexual development will be delayed, and in adults, the libido would be significantly lower than the normal. Apart from poor sexual development, the endocrine abnormalities are also pretty common. Another important feature is the patients with anorexia nervosa refuse to accept that they have a problem. They say that my weight is normal, my appetite is normal, I am eating enough food. They refuse to accept that they have a problem. They are very secretive about their illness, and that is why it is difficult to treat them. Now, there are two subtypes of anorexia nervosa. So the first one is the restrictive type, where patients restrict their food intake. They don't eat food at all, or they eat food minimally. There is another type in which usually the food intake is severely restricted, but then there are episodes of binge eating and purging. What is binge eating? Large amount of food is ingested in a small duration of time, and purging means taking it out. People may induce vomiting or may induce diarrhea to take it out to prevent the weight gain. So while the restrictive type is pretty common, but binge eating purging type can also be seen in these patients. This is important because a lot of times you make a mistake. You equate binge eating and purging with bulimia nervosa. The moment you see in the paper that it says that the patient indulges in binge eating or purging, you automatically go and take the bulimia nervosa diagnosis. That is not true. That is not correct, because binge eating and purging can be seen in both anorexia nervosa as well as the bulimia nervosa. The treatment is tough because patients do not accept it, but if the weight has decreased significantly, or if the patient is developing electrolyte imbalances, or there is significant dehydration developing, in those cases, many times you have to admit the patient. Especially if the weight for height has decreased by 20%, that is an indication for admission. After admission, usually behavioral therapy is used, and sometimes medicines like SSRIs or cyproheptadine can also be used. But the mainstay of the treatment is psychotherapy. Let's talk about bulimia nervosa. Now, patients with bulimia nervosa also have fear of gaining weight, but bulimia nervosa symptoms are not as severe as symptoms of anorexia nervosa. The quintessential symptom of bulimia nervosa is episodes of binge eating, where in these episodes what happens is the patient ingests large amount of food in a small duration of time. Now once they have had lot of food, now they are worried that they would gain weight. So now they indulge in inappropriate ways of stopping weight gain. So they have ingested a lot of food, now they will do something to prevent weight gain. This something is usually purging. They will use either laxatives, they will use either diuretics, but the most common way is just inducing the vomiting, right? So purging is mostly done by self-induced vomiting, but there can be use of laxatives and diuretics also. Another way is the person eats a lot of food, and then to burn the calories, they go for extreme exercising. Say a girl eats 4 chapatis in one go, and then she goes for a 6-kilometer run. This is called as hypergymnasia. Now what happens is, as I said, usually the pattern is to induce vomiting. And what do these patients do? They take two fingers and they put it inside the mouth. They try to scratch the pharyngeal wall, which would result in gag reflex, and that would result in vomiting. So when you do it again and again, what happens is the knuckles keep on getting injured against the teeth, and that may result in development of calluses. So callousy knuckles. Apart from that, because of repeated vomiting, the teeth may get damaged. There may be development of dental caries. Apart from that, the glands may become inflamed. The parotitis may develop. And also what may develop is the alkalosis. If you are vomiting again and again, the acid is coming out again and again, that would result in, of course, metabolic alkalosis. In vomiting, we know that the potassium is lost and the chloride is lost. So hypokalemic and hypochloremic metabolic alkalosis may also develop. Again, remember, these are the signs of purging. If a patient with anorexia purges, she will also develop all these signs. So if you find these signs in a question, don't automatically believe that the patient is of bulimia nervosa. It could be of any of those. So how do we differentiate? The best way to differentiate bulimia nervosa from anorexia nervosa is the weight. The patients with bulimia nervosa usually have normal weight, whereas a patient with anorexia nervosa has significantly lesser weight. Apart from this, the endocrine abnormalities are rare in bulimia nervosa. The sexual development is usually normal in bulimia nervosa. And these patients are much more open about their diagnosis. They often come and they seek help from the doctor. And what is the treatment? Again, usually psychotherapy in the form of behavioral therapy. Please remember, all the eating disorders are much more common in females in comparison to males. Let's talk about sleeping disorders. Now again, usually the questions they ask are from NREM disorders. We can divide the sleeping disorders into NREM disorders and REM disorders. And in NREM, usually these disorders occur in NREM stage 3 or NREM stage 4. Now, first of all, let's talk about night terrors and nightmares. So when do we dream? Do we dream in NREM or REM? The answer is we dream in both. But we tend to remember the dreams that we see in REM. Now in both night terror and nightmare, what happens is the child, usually seen in children, these disorders are usually seen in children, the child sees a scary dream and he gets up, and because he saw a scary dream, there are signs such as palpitations, restlessness, sweating, all these signs are there. But if he saw the dream in the NREM sleep, he would not be able to remember anything about it. On the other hand, if he saw the dream in REM sleep, he would be able to remember it. So the history that we get in night terror, which occurs in NREM sleep, is the child wakes up in the night, looks all hassled and scared, does not recall what happened, is not able to remember the dream, usually goes back to sleep and is not able to recall anything the next day. This is what happens in night terror. But if the same dream he saw in REM sleep, then we call it nightmare. What is the history? The child sees a scary dream, wakes up in the night, looks all scared and hassled, is able to tell the family members that he saw a scary dream, goes back to sleep and remembers everything the next day. This is the difference between night terror and nightmare. Night terror is also called as sleep terror or pavor nocturnus. The second NREM disorder is somnambulism. This year NEET question. We all know what somnambulism is. Sleepwalking. The child may get up in the night, may walk around a bit, usually comes back and goes to sleep. Now, while he is walking, is he completely conscious? The answer is no. It is happening in the NREM stage. So the consciousness is not completely preserved. This was the question in the NEET exam. Which of the following statements is incorrect about somnambulism? And one of the options was consciousness is completely preserved. That is not true. It is a sleeping disorder. How can the consciousness be preserved? Then we have got enuresis, and particularly nocturnal enuresis, where the child is indulging in bedwetting. We do not diagnose nocturnal enuresis till the age of 5 years. If the child is bedwetting till 5 years, it is considered as developmentally normal. What is the treatment of choice for nocturnal enuresis? The answer is bed alarms. Behavioral therapy in the form of bed alarms. But if somebody asks you what is the medicine of choice or drug of choice for the treatment of nocturnal enuresis, the answer is desmopressin. Bruxism. What is bruxism? We know teeth clenching or jaw grinding. Now, while all the other disorders are usually seen in NREM 3 or 4, bruxism is usually seen in NREM stage 2. And finally, we have got somniloquy. What is somniloquy? Sleep talking. The child talks in the while sleeping, and it's called as somniloquy. Now, for all these NREM disorders, or in fact for even nightmare also, we usually do not have to treat the child. Just reassuring the parents that it is a temporary phase and it would go away is what is needed. But sometimes if the symptoms are significant, then we can use benzodiazepines, and benzodiazepines, by decreasing the duration of NREM 3 and 4, are able to decrease the symptomatology. Another important REM disorder that we must talk about in details is narcolepsy. Now, in narcolepsy, what happens is REM sleep intrudes into the wakefulness. So what would be the symptoms? The first symptom is the presence of hallucinations, hypnagogic and hypnopompic hallucinations. What are hypnagogic hallucinations? Hallucinations that occur while going to sleep. And what are hypnopompic hallucinations? Hallucinations that occur while getting up from sleep. The second symptom is cataplexy. What happens is, say you are awake and suddenly REM sleep enters, you would lose all the muscle tone and you would fall down. The sudden loss of muscle tone is called as cataplexy. Please do not confuse cataplexy with catalepsy. If you remember, catalepsy is a motor sign of schizophrenia. Cataplexy is sudden loss of muscle tone. Then we have got sleep attacks. When the REM sleep intrudes, the patient feels so sleepy that he is not able to control himself. He will go into a sleep no matter what he is doing. Whether he is driving, whether he is swimming, whether he is walking, he will just go into sleep. That's why it's called a sleep attack. It's an attack of sleep. And then we have got sleep paralysis. Now, sleep paralysis is something that happens sometimes to normal people also. I'm sure it must have happened to you once in a while, where you get up in the morning, you are awake, but you are not able to move yourself. That is called a sleep paralysis. So it is a common feature of narcolepsy. Now, narcolepsy has been found to be associated with HLA class 2. Now, the current understanding of narcolepsy is it's a kind of an autoimmune disorder where the autoimmune reaction results in destruction of the neurons which secrete hypocretin. The deficiency of hypocretin is what results in development of narcolepsy. Hypocretin is something that promotes wakefulness, and if it is lost, it can make a person vulnerable to all these symptoms. What is the drug of choice for narcolepsy? Obviously, all of us know that it is modafinil. Modafinil is a stimulant. Also, we tell the patient that take naps regularly in the daytime. When the person takes naps, the chances of those sleep attacks goes down significantly. Lastly, let's talk about a syndrome called as Kleine-Levin syndrome, also known as Sleeping Beauty syndrome. And what happens in Kleine-Levin syndrome is there's a triad of hypersomnia, hyperphagia, and hypersexuality. This is a triad. And what is the drug of choice for Kleine-Levin syndrome? It is modafinil. So this is about the sleep disorder. Let's talk about sexual disorders. Before that, let's talk about the sexual response cycle. Now, there are multiple stages through which the body goes during a sexual response. The first stage is, of course, of desire, the desire to indulge in sexual activity. The second stage is that of excitement, when the body starts to react. In this stage, there is erection of the penis and there is lubrication of the vagina. The last part of excitement stage is called as pleasure phase. And following the pleasure phase, there is orgasm. Orgasm phase where males ejaculate. Now, orgasm is the shortest phase of the sexual response cycle. This question has been asked multiple times in the NEET pattern exams. And after the ejaculation, after the orgasm, there is resolution phase where the body gradually goes back to the baseline. Now, one of the important sexual disorders that we must be aware of is GID, or gender identity disorder. The newer name of GID is gender dysphoria. So what is gender and how is it different from sex? So sex is more of an anatomical construct, what the sexual organs are. Gender is more of a psychological construct. Gender is defined as a sense of being a male or a female. What you consider yourself to be would be called as your gender. Now, usually sex and gender are same. Somebody who has male sex organs would consider himself to be a male. But at times that is not the case. And that results in development of GID, or gender identity disorder. So GID has different manifestations in the childhood versus in the adolescence or adulthood. A child who has GID does not have a lot of understanding about the anatomical sexual organs. About the sexual organs anatomy, he is not really aware of. So the symptoms are something like this. The child would prefer wearing the clothes of the other sex. So say the child is a boy, he would prefer wearing frocks and all, which are usually used by girls. Not only the clothes, but he would also prefer to play in a way which usually is associated with the opposite sex. For example, he would prefer playing with dolls and all rather than playing with the guns and the cars that usually boys play with. At times the child may say that, at times the child may express that he wants to be a girl, but he is not mature enough to make a comment upon the sexual organs, right? But the situation changes when this child reaches adolescence or adulthood. Now what happens is, first of all, the term used is transsexualism. Now transsexualism is the full-fledged form of GID, usually seen in adolescents and adults. Now the patient has grown up. Now he clearly says that he is not happy with his sex organs and he is uncomfortable with his sex organs, and he goes on to say that he wants to change the sex organs and convert into the opposite sex. Typically the question that they give in the exam, it has a line that either the line will say, the patient says he's a man trapped in a woman's body, or she is a woman trapped in a man's body, right? This is the typical line that they give in the exams. So if you see this line, the answer is transsexualism or GID. How do you treat these patients? If the symptoms start continuing for too long a time, for a longer duration, you don't have any other option but to actually change the sex of the patient by doing SRS, sex reassignment surgery. After that, let's talk about the erectile dysfunction. Now we know what is erectile dysfunction: inability to either achieve erection or maintain erection required for sexual intercourse. Now erectile dysfunction, the most common cause is psychogenic, the performance anxiety. But in some cases, there is actually an anatomical or physiological problem. There may be a disturbance of the vascular supply of penis or the nerve apparatus of penis. And these conditions are called as organic ED, where something is really wrong with the blood supply or the nerve functioning. And the most common cause of organic ED is diabetes. How will we differentiate whether the patient is having psychogenic ED or organic ED? It's pretty simple. First of all, we take the history. Now we know that males normally have erections during REM sleep. During REM sleep, males have erection. So if it is psychogenic ED only, if the patient is not able to have erection only because of anxiety, at least during the sleep when there is no anxiety, he should be having erections. So if he is having nocturnal erections or early morning erections, then it goes towards the diagnosis of psychogenic ED. If he is not able to have erections even in the night time, then it goes towards the diagnosis of organic ED. Rather than relying solely on the history, a test can be done called as nocturnal penile intumescence, which does the same thing. We basically measures whether the patient is having erections in the night time or early morning, and the results are also the same. If he is having erection in the night time, psychogenic ED. If he is not having erection in the night time, organic ED. How do we treat erectile dysfunction? All of us know the drug of choice is the phosphodiesterase 5 inhibitors like sildenafil or tadalafil. Apart from that, there are certain other drugs like L-prostadil, which is a prostaglandin. It can be used as an intracavernosal injection or transurethral. It can also be used for the treatment of ED. And there is a psychotherapy called as dual sex therapy or sex therapy. This can also be used in the treatment of ED. Now this therapy was given by a couple called who are named as Masters and Johnsons. That is why it is also called as Masters and Johnsons technique. The important thing about the dual sex therapy or Masters and Johnsons technique is that we treat a couple. Of course, erectile dysfunction happens to a male, but when you treat it using this therapy, you call the couple and you take the couple for treatment. This has been asked in the exams. The next diagnosis is premature ejaculation. It is a disorder of orgasm phase. This was recently asked in the exams. And how is it defined? Now DSM-5 defines PME as ejaculation happening in less than 1 minute. If the ejaculation is happening in less than 1 minute, it is called as PME. And what is the cause? Usually it is psychogenic in nature. How do we treat PME? Selective serotonin reuptake inhibitors, they have a side effect. That is, they delay the ejaculation. But that side effect becomes effect in PME. So SSRIs are the main drugs used. But apart from using SSRIs, there are certain techniques that can be used for the treatment of PME. So the first one is called as squeeze technique, in which when the patient feels that he is about to ejaculate, the penis is squeezed using a thumb and 2 fingers. And the other one is called as stop and start technique, where when the patient feels that he is about to ejaculate, he stops having sex, waits for 15-20 seconds, and then again starts having sex. So this has been asked again. Squeeze technique is used in the treatment of ED, PME, hyperactive sexual desire disorder, something else. The answer would be PME. Alright, let's talk about child psychiatry. We'll start with ADHD, attention deficit hyperactivity disorder. The older name for ADHD was minimal brain dysfunction. This was asked in the recent NEET exams. Now, most of the questions that come from ADHD are on the diagnosis. They will give the history of a child and you are asked to make a diagnosis. Now, this is pretty simple because the symptoms of ADHD are there in the name itself. The first symptom is attention deficit or inattention. So what is the history that is given for inattention? The question will say that the child is not able to give attention to the work, is not able to give attention to the details of the work, and he is very distractible. He starts one activity, then becomes distracted, leaves it and go to some other activity, makes a lot of mistakes in the school. This is the history that is given for inattention. Then the second symptom is hyperactivity. The question usually says that child is not able to sit at his desk in the class, keeps on roaming around in the class, does not sit and disturbs other students too. And then there is history of impulsivity, where the child is not able to control himself. He will not be able to wait for his turn, and sometimes if a question is being asked to him, he would not be able to wait for the question to get completed and he will blurt out the answers. So answers before the question is complete. These are the 3 main symptoms of ADHD. In the older classifications, it was said that the symptoms should start before 7 years of age to make a diagnosis of ADHD. But in DSM-5, that criteria was increased to 12 years. Now we say that if the symptoms have been there before 12 years of age, the diagnosis of ADHD can be made. ADHD is of course usually seen in boys. And around 50% of these children with ADHD, by the time they reach their puberty, they achieve remission. The symptoms remit. The problem in those 50% who do not have remission of symptoms. So they are predisposed or vulnerable to development of 2 things. The first one is antisocial personality disorder, and the second is alcohol and other substance use disorder. Because the consequences can be really bad, really severe. Hence we say that ADHD should not be taken lightly. It's a serious medical illness and must be treated with pharmacotherapy. In fact, this was a question asked in the AIMS exams. When we talk about the pharmacotherapy of ADHD, what is the drug of choice for ADHD? The answer is methylphenidate. We preferably use stimulants such as methylphenidate, and then there are other stimulants like amphetamines, dexmethylphenidate, modafinil. Non-stimulant medications can also be used. They are not so effective, but they can also be used, and they include ABC, atomoxetine, bupropion and clonidine. We can also use guanfacine and venlafaxine. Alright, let's talk about pervasive developmental disorders. Now this is an older term. So what is pervasive developmental disorders? They are a group of neurodevelopmental disorders which manifest as the child grows up. The most famous of them is autism. Now again, when it comes to autism, the vast majority of questions are asked from the diagnosis. So we must remember the diagnosis, we must remember the symptoms of autism. The first and the most important symptom of autism is impairment of social interaction. The child does not interact properly the child does not have a proper social interaction. How does it manifest? In the infancy, the child would not show the social smile. As he grows up, the eye contact is poor. When he further grows up, he is not able to make friends. When he further grows up, he is not able to make boyfriend or girlfriend. Although in India even normal people are not able to make boyfriends and girlfriends, so we can leave that. But the point is that the social interaction is impaired. The second important symptom is impairment of communication and language. Classically, the question usually say that the language milestones of child are delayed. They will say that the motor milestones are normal, but the language milestones are delayed. The child is not able to communicate. Even the non-language communication by gestures, even that is impaired. And then there is a pattern of restricted repetitive patterns of behavior. The child tends to behave in the same way again and again. There can be stereotyped movements. If you remember the first chapter, we talked about the stereotyped movements. The child will make the same movement, purposeless movement again and again. The child may make the same kind of sound again and again. Around 30% of children who have autism, they also have comorbid mental retardation. And abnormality of dermatoglyphics, the fingerprints, it is also commonly seen in patients with autism. Another important pervasive developmental disorder which is often tested in your exams is Rett syndrome or Rett's disorder. It is almost exclusively seen in females, and the history is very typical. For the first 5 months of her life, the child is perfectly fine, perfectly normal. The symptoms start to show up between the 5th and the 48th months of life. And the most classical symptom is the deceleration of head circumference. The growth of the head falls behind or lags behind the growth of the rest of the body. So what happens is, in comparison to rest of the body, the head keeps on becoming smaller and smaller, and finally we see microcephaly. So a typical question is, all of the following are features of Rett syndrome except, and one of the options would be macrocephaly. So we don't see macrocephaly, we see microcephaly. Apart from this, there is loss of acquired hand skills and speech. So say the child had reached the stage of pincer grasp, now she will lose it, she might go back to palmar grasp. Whatever skills she had developed, she will regress and lose them. Apart from this, there is disturbances of gait and ataxia, and the 3 symptoms that we talked about in autism: disturbances of social interaction, disturbances of communication, and restricted repetitive patterns of behavior. They are also often seen in patients with Rett syndrome. 75% of these children have seizures, and another point sometimes asked in the exams is major reason for death in these children is cardiac arrhythmias. Now in the recent classification, the autism, the Rett syndrome, and some other types of PDD, all of them have been clubbed together into a single diagnosis of autism spectrum disorder. So now both of them have been clubbed along with Asperger syndrome and some other disorders, and now the only diagnosis that we use is autism spectrum disorder. Another important thing is, in the criteria of autism spectrum disorder, the criteria of disturbance of communication and language has been removed. So we don't need that criteria to make a diagnosis of autism spectrum disorder according to newer classification. But in all likelihood, the question would still be asked from the older classifications, so you should remember this. Let's talk about mental retardation. Now, first thing first, the newer name of mental retardation according to DSM-5 is intellectual disability. So when we talk about MR, we have to talk about IQ, intelligence quotient. What is IQ? Mental age divided by chronological age multiplied by 100. Now in this formula there is a catch. The denominator can never be put more than 15. You cannot put denominator as more than 15 years. Say a question is given, a child who is aged say 18 years comes to you, and when you do the mental age, you find that the mental age of the child is 7.5. What is the IQ of this child? So the age of the person is 18, chronological age is 18, mental age is 7.5. What would be the IQ? Ideally, we should go 7.5 divided by 18 into 100, but I just said that denominator cannot be more than 15. So we write 7.5 divided by 15 into 100, which comes out to be 50. Now normal IQ is between 90 to 109. Borderline intelligence is IQ between 70 to 89, and anything less than 70 is mental retardation. We can further divide it into mild MR 50 to 69, moderate MR 35 to 49, and severe MR 20 to 34. And the most severe form is profound MR with IQ less than 20. Two questions. What is the most common chromosomal cause of MR? What is the second most common chromosomal cause of MR? Answer is Down syndrome is the most common cause, and second most common cause is Fragile X syndrome. Although there is some controversy about Fragile X, sometimes we say that Fragile X cannot be considered as a chromosomal cause, but this is what that has been asked in the exams, and this is what they gave as an answer. Alright, let's talk about the topic of psychoanalysis. Now this is a very interesting, at the same time very confusing topic. Now, who is the father of psychoanalysis? This gentleman, Sigmund Freud. Sigmund Freud is the father of psychoanalysis. According to the theory of psychoanalysis, the childhood experiences and unconscious internal conflicts going on within the mind of the person, and the childhood experiences are responsible for development of psychiatric disorders. Now, this theory was given by Sigmund Freud. Sigmund Freud also proposed topographical theory of mind, and this question was asked in the recent NEET exam, who gave the topographical theory of mind? The answer is Sigmund Freud. Sigmund Freud gave a topographical theory of mind in which he said that there are three components of mind: conscious mind, pre-conscious mind, and unconscious mind. So basically, conscious mind is all those things that you are aware of. Everything that you can remember, recall, is in your conscious mind. Things that you cannot recall, no matter how hard you try, they are in your unconscious mind. And pre-conscious mind is things that you can recall by putting some efforts. Now, Freud said that there are a lot of things that are hidden in the unconscious mind, and they result in development of psychiatric disorders. So Freud said that if somehow we can recall those things, we can bring those things from the unconscious mind to conscious mind, that would result in the resolution of psychiatric disorders, and he proposed various ways of doing it. The first way given by him is called as free association. Now, what happens in free association? The patient is asked to speak whatsoever that is coming in his mind without putting any filters. Patient is told, even if a bad word is coming to your mind, even if something that is very irritating or embarrassing is coming into your mind, even that should be expressed by you. There should be no filters. This is called as freely associating. When a patient freely associates, Freud said things that are hidden in the unconscious mind, they tend to slip out in the form of slips of tongue. Apart from that, Freud said that the dreams that we see, they are not random. The dreams that we see, Freud said that they derive their content from the unconscious mind, and if we can somehow interpret the dreams, we will understand what is going on in the unconscious mind of a person. Now, sometimes when we use these techniques, patients are able to recall the long forgotten things, and when they remember those long forgotten things, sometimes they have a great amount of emotional discharge. Say somebody is able to recall some abuse that was done to him when he was a child. When he or she recalls it, he might become very angry or very sad or may start shouting. So this recall of memories along with the emotional discharge is called as ab reaction. Alright. Now, after some time, Freud gave another theory which is called as structural theory of mind. Now, according to the structural theory of mind, Freud said that there are three components of mind. This time he said that they are id, ego, and superego. Freud said id is that part of our mind that operates on pleasure principle. It is the part of your mind which wants to have fun, which does not care about anything, which does not care about any kind of consequences. It just wants to enjoy. Superego is, on the other hand, the part which works on the morality principle. The part of your mind which tells you to work hard, to respect the elders, to be punctual, to have high morals of high values of living. All those things come from the superego. And then who are you? You are stuck in between both of these. You are the ego. You know that too much of pleasure is not good and too much of principles are also not good. So you try to balance both of them. For example, if you are listening to this lecture, your id wants you to shut the lecture, go out, have fun, maybe have some drinks and enjoy. Your superego is telling you that listen to the entire lecture, do the MCQs also today, do the revision also today, and finish the course today itself. And in between you are stuck and you are thinking that I will finish a part of it and then I'll go and listen to music. So you keep on balancing, you keep on doing the balancing act. This is the function of ego. So many times id and superego clash, and that creates anxiety, and ego has to use certain mechanisms to prevent the buildup of that anxiety. So these mechanisms are called as defense mechanisms. So these are the unconscious mechanisms used by ego to prevent the buildup of excessive anxiety. Now there are many defense mechanisms. We will stick to a couple of them which have been frequently asked in the exams. So the first defense mechanism that you must be aware of is displacement. Displacement is transfer of emotions from one individual to another individual. For example, say you go back to your home and for some reason your father scolds you a lot. You become very angry, but you cannot do anything. So what you do instead is you go into the room of your younger brother and you start beating him. This is displacement. You have displaced the emotions from one individual to another individual. Now remember this fact that displacement is the primary defense mechanism used in patients who have phobia. Often this question will come in the exam. In phobia, which is the defense mechanism that is involved? The answer is displacement. The second defense mechanism is reaction formation. Reaction formation is transformation of an impulse into its exact opposite. What you really want to do, you start doing the exact opposite of it. For example, say Valentine's Day is coming and you want to go on a date, but not a single girl is ready to go out on a date with you. You are very frustrated. So what you do is you start saying that Valentine's Day is against Indian culture and you start beating the other couples who are going on a date. This is reaction formation. Then we have got isolation of affect. Removing the feelings associated with a stressful event. There is a stressful event, but the mind removes the associated feelings. For example, a middle-aged woman who was diagnosed with, say, pancreatic cancer in the morning, comes back home in the afternoon and without showing even a tinge of emotion, tells the family members that I have developed pancreatic cancer. She has removed the emotion from the content. Then we have got undoing, an act to nullify the previous act. So for example, say you had a fight with your partner or friend, and then the next day you take a gift to that partner or friend. You are trying to undo what happened the last day. The next one is aim inhibition. What happens in aim inhibition is the person accepts partial fulfillment of desires. Rather than going for the complete fulfillment, you settle down with partial fulfillment. For example, say somebody wanted to become a doctor, somebody wanted to become a physician, but despite taking multiple attempts at PMT exam, he was not able to qualify. So instead, he settles down for becoming a vet doctor, right? This is aim inhibition. Now, all these defense mechanisms that you can see on the screen, all of them are involved in the development of OCD or obsessive compulsive disorder. From displacement to reaction formation till aim inhibition. All of these are seen in patients with OCD. Just remember all of them, they are all seen in OCD. Lastly, in this chapter, we talk about the psychosexual stages of development. Now, the psychosexual stages of development were given by obviously Sigmund Freud. Freud said that the human sexuality develops in certain stages, and what he meant by sexuality was the way or the method in which humans derive pleasure, not only about sex but pleasure in general. So Freud said when a child is born, he is in oral stage. He gets pleasure by biting on things, by cutting things. That is why we see that children try to put everything in the mouth. So oral stage continues from 0 to 18 months. Then comes the anal stage from 18 to 36 months. Now in this stage, the child is trying to become toilet trained. Becoming toilet trained gives him a sense of achievement that I am able to master my own body. So this is called as the anal stage. Fixation at anal stage results in OCD. Remember this phrase, fixation at anal stage. Fixation means if the sexual development, if the psychosexual development stops at anal stage, it results in development of OCD according to Sigmund Freud. Now this is what Freud said. Today we know that OCD is because of multiple neurotransmitter disturbances, but at that time Freud said that it is because of fixation at anal stage. The next stage is called as phallic stage, which goes from 3 to 5 years. Now in boys during phallic stage there is development of Oedipus complex. Last year NEET question, Oedipus complex is seen in boys who are 3 to 5 years of age. What is Oedipus complex? The male child develops sexual feelings towards the mother and develops aggression towards the father, and this complex gets resolved when male child makes the father as the role model. The same thing in female child is called as Electra complex. Female child develops sexual feelings towards the father, develops resentment towards mother, and finally makes mother as the role model. What you need to remember is the age and the name of complexes. Freud said fixation at phallic stage can result in development of neurosis. This next stage is called as latent stage. Now latent stage is where the sexuality becomes dormant. The child does not think about sex and all, and he instead focuses on gaining skills. He focuses on learning and gaining skills that would help in the future life. Normally the stage goes from 5 years to 12 years, but if the children goes into a medical college, sometimes the stage continues till 30 years. That's a joke. Alright, and lastly the genital stage. Now genital stage continues from 12 years till like young adulthood, and this is the age when the child reaches puberty and develops adult sexual functioning. So this is about psychoanalysis. Alright, let's talk about an act, Mental Health Care Act, which recently came into effect. It was published in 2017, called as MHCA 2017, and the examiners have been asking questions from this act. So we need to talk about some important components of this act. The first one is Advance Directive. Now what is Advance Directive? So basically what happens in Advance Directive is the person, while he is in good state of mind, while he has the capacity to take decisions, the person can write down on a piece of paper that if tomorrow I develop a mental illness and I'm not able to take mental health care decisions for myself, these are the methods or these are the ways in which I would like to be treated, and these are the things that I would not want for myself. For example, today I write down on a piece of paper that if tomorrow I develop a mental illness and lose the capacity to take mental health care decisions, I can only be treated in an outpatient on an outpatient basis. I am okay taking medications, but never ever admit me. I do not want to get admitted if this happens. So tomorrow, say 6 months later, 1 year later, I develop schizophrenia and I lose the capacity to take mental health care decisions. The doctor who treats me will have to follow those advance directives. He cannot admit me. He will have to treat me on an outpatient basis. This is advance directive. Now the second thing that is important in Mental Health Care Act is, apart from writing this piece of paper, I can also assign a person the responsibility to take care of me. I can say that if tomorrow something happens to me, I'm not able to take care of my, I'm not able to take mental health care decisions, my wife would be helping in taking the mental health care decisions for me. So I nominate somebody. This is called as nominated representative. I nominate my wife who would take mental health care decisions for me. The third thing that is important in MHCA is ban on direct ECTs. Now we know that there are two types of ECTs, electroconvulsive therapy, direct and indirect. What is the difference? In direct ECT, we do not use anesthesia and we do not use muscle relaxants. In indirect ECT, we use anesthesia and we use muscle relaxants. So now the government has banned direct ECTs. Government has also banned all kind of ECTs in minors. If somebody is less than 18 years of age, you cannot give ECT to them. But if a psychiatrist thinks that giving ECT in a minor is quintessential, it's very important, then what he can do is he can move an application to a government appointed board called as mental health review board. He can give an application that, look, this child needs ECT, and if the board accepts it, then you can give ECT in a minor. Otherwise, you cannot give ECT by yourself. You'll need to take permission from the government. Similarly, for psychosurgeries have been banned, but if you think it is required, move an application to the board. If they allow it, you can do it. And lastly, there was a section 309 of IPC, Indian Penal Code, which criminalizes the suicide attempt. Now, the Mental Health Care Act has decriminalized the suicide. Now, the Mental Health Care Act says that if somebody attempts suicide, it would be presumed that they are under severe stress and they would not be prosecuted against. So remember all these points, they are important. Some of them have already been asked in the exams and others are likely to be asked. Alright, finally, a couple of points on the topic of organic mental disorders. The main part is dementia, which has been taken care of by Dr. Marwa in his lectures. So I'll touch upon few points only. So first of all, what are organic mental disorders? Now, the disorders in which there's a clear and demonstrable abnormality of brain, where we can clearly show that this part of brain is not functioning, they are called as organic mental disorders. And usually the organic mental disorders include delirium and dementia. Now, delirium, it is the most common acute organic mental disorder. Now, there are three important symptoms of delirium. The first and the foremost is disturbance of consciousness. The person is not having complete or full level of consciousness. You will be seeing different terms for disturbances of consciousness. The examiner may say the patient is confused. The examiner may say the patient has clouded consciousness. The examiner may say that he has reduced consciousness. They may say that the patient has altered sensorium. All of these point towards the disturbances of consciousness. Secondly, there is disorientation to time, place and person. Now, when a person loses orientation, the first thing that he loses orientation to is time, then place and then person. And when the orientation comes back, the first thing that comes back is orientation to person, then place, then time. And the third symptom includes hallucinations, all kind of hallucinations, but most common are visual hallucinations. Out of these three main features, the most important one is the first one, disturbance of consciousness. Delirium is primarily an abnormality of disturbance of consciousness. Now, how is the diagnosis of delirium made? The diagnosis of delirium is a clinical diagnosis. Basically, you make a diagnosis on the basis of symptoms. The investigations are not confirmatory. But sometimes they ask you, what is the most common investigation finding in delirium? The answer is diffuse slowing on EEG. On electroencephalogram, you will see diffuse slowing on all the montages. The exception is alcohol withdrawal delirium and the benzodiazepine withdrawal delirium. In those cases, fast activity is seen on EEG, not the slow waves. How do you treat the delirium? You treat the cause. Whatever is causing delirium, you treat it. For example, if you remember, we talked about delirium tremens. What is delirium tremens? It is nothing but alcohol withdrawal delirium. Delirium happening in alcohol withdrawal. How do you treat it? By giving benzodiazepines. By treating the withdrawal symptom, you treat the delirium. Now, typically the question that comes on delirium is this. They will give you history of a patient who never had any psychiatric illness in the past, and then they will say that he developed a medical condition. It could be an infection, it could be burns, it could be heart attack, it could be surgery, it could be some fracture. And then they would say that patient suddenly develops those three symptoms. They will ask you the diagnosis. For example, a 40-year-old male fell from the bed and developed hip joint dislocation. He was admitted and operated upon. He was recovering well when on the third day post-operative, he appeared confused. What is appearing confused here? Disturbance of consciousness. Then the question further says, the patient is not able to identify the doctor and says that he is in a jail while he is lying in his wardroom. What is happening here? Disorientation to person and disorientation to place. The patient further says that small insects are crawling all around him. What is it? Visual hallucinations. And then the question will ask you, what is the diagnosis? The answer is delirium. And lastly, the difference between delirium and dementia. Now, books give long tables, talk about many points, but if you remember these 3 points, you would be able to differentiate all the questions of delirium from dementia. The first and the foremost, delirium always has an acute onset. The symptoms come suddenly. Whereas dementia has an insidious onset. The symptoms develop gradually over a period of months or years. In delirium, disturbances of consciousness is the primary symptom. In dementia, we never ever see any disturbance of consciousness. And finally, the course of delirium is fluctuating. The symptoms may be worse in the morning, may improve in the afternoon, may worsen in the evening. It fluctuates a lot. Whereas dementia has a steady and progressive course. Usually the symptoms increase only, they don't fluctuate like that. So just remember these 3 points and you would be able to answer most of the questions of delirium and dementia. Alright students, this is all about it. So what we have tried to do is, we have tried to cover all the high yield point in psychiatry, all the high yield topics in just like 4.5 hours. And I hope that this material would help you in getting most of the questions correct from the subject of psychiatry. I would suggest you that you spend at least 2 days in listening to these lectures and doing the questions. And I want to wish you the best of luck for your exams. Thank you.